Accountability. I am Prakriti Sharma speaking on behalf of Nepal Health Resource Council NHRC, and it is an honor to facilitate this session, which promises enriching discussion and insight. Without further ado, let me first introduce our distinguished session chair, Dr. Nurain Mohammad Noor. Dr. Noor, please come on stage. Dr. Nurin is the chairman of Medical Research and Ethics Committee, consultant endocrinologist, and head of the Clinical Research Center in Putrajaya Hospital, Malaysia. Additionally, she is the president of Malaysia Endocrine and Metabolic Society for 2002-2024 term. Her extensive expertise in medical ethics and research will undoubtedly provide invaluable direction for this session. Next, I am equally privileged to introduce our another session chair, Dr. Prakash Khimire. Dr. Khimire is a professor at Central Department of Microbiology, Tribhuvan University, and former ethics chairperson of the Nepal Health Resource Council, NHRC. So please take your seat. Now, I would like to hand over the session to our chairs. Over to you, chairs.
Thank you. Thank you, Prakriti.
Namaste and a very warm good morning, respected chair and co-chair, all the national and international delegates of 24th FERCAP International Conference 2024. I am Dr. Suveksha Saurya, currently an intern doctor. I'll be presenting my research on a retrospective study of profile of leprosy patient. So we all know that Nepal has already achieved the elimination of leprosy as a public health problem already 1.5 decades back in 2010 AD. But still we are seeing cases of leprosy being reported. And there is where I saw a research gap and I decided to do research in this topic. During my 4th year of MBBS when I was posted to Lalgarh Leprosy Hospital in Health Service Management Field Program. So our study aims to determine the number of patients with leprosy, lepra reaction, determine the category of leprosy that they fall on, the grade of disability, and the presence of ulcer among them. The bacterial load in skin slit smear examination through histopathology from January 2019 to January 2024, a total of 5 years of study period duration. So let's go through some of the operational definition that we'll be going through in a couple of slides. So paucibacillary is a case of leprosy with 1 to 5 skin lesions without demonstrated presence of bacilli in skin slit smear. And a multibacillary case is a case of leprosy with more than 5 lesions or with nerve involvement or with demonstrated presence of bacilli in skin slit smear, irrespective of the number of skin lesions. So lepra reaction is the reaction in which the existing leprosy lesions become red, warm, swollen, and tender. And it can even manifest as acute neuritis in a nerve. And lepra reaction type 2 is also known as erythema nodosum leprosum, ENL, which mainly occurs in patients with high bacillary load. And the key diagnostic feature is sudden appearance of tender nodules in the skin. And they even may ulcerate in severe cases. And systemic symptoms might occur, such as high-grade fever, joint pain, and fatigue. So the methodology of the study, this study is basically a retrospective cross-sectional study which included all the new patient diagnosed with leprosy at Lalgarh Leprosy Hospital and Service Center from January 2019 to January 2024, a total of 5 years of study period duration, as I had already mentioned earlier. And so data were basically collected from hospital record, including variables such as age, sex, address, type of leprosy, type of lepra reaction, grade of disability, and the bacterial load in skin slit smear. And the data were double entered into Microsoft Excel and was analyzed using SPSS version 20. So the ethical approval for this study has been taken from National Health and Research Council NHRC, Kathmandu, Nepal, with reference number 1076 on 18 Jan 2024. So after the ethical approval, all the data collection and analysis was done. So now the most awaited part, that is results and discussion. So out of 4,655 patients diagnosed with leprosy, 39% were female and 61% were male, which shows a male predominance. So talking about the age distribution among the leprosy patient, we can see the highest is in the age group 20 to 29, and the most significant finding is 582, which is 12.5% were children aged 3 to 16 years. And the presence of newly diagnosed child cases in this study points an active disease transmission of leprosy in community, which is definitely a matter of concern to all of us. And the most common type of leprosy was multibacillary with 59.8%, followed by possible bacillary, which was 40.2%. Now, some more operational definition of WHO disability grading. WHO has graded the disability into grade 0, 1, and 2. In grade 0, there is no eye problem, there is no any evidence of visual loss. In hands and feet, there is no anesthesia, there is no visible damage or deformity. In WHO grade 1, in eyes, there is no eye problem. In hand and feet, there is anesthesia present, but no any visible deformity. And in grade 2, in eyes, there is severe visual impairment, and the patient may also have lag of thalamus, iridocyclitis, and corneal opacities. And in hand, feet, there is a visible deformity seen in the leprosy patient. So we can see here 978, which is 21% developed WHO grade 2 disability, and 484, which is 10.4% developed WHO grade 1 disability. So we can see the ulcer on diagnosis. 290, which is 6.2% patient had developed ulceration at the time of diagnosis. So lepra reaction. 37.3% of patients developed lepra reaction. Among them, 35.4% with type 1 lepra reaction, and type 2 lepra reaction was present in 1.4%, which is 64 patients developed type 2 lepra reaction. So we can see this is a graph showing bacterial index in skin slit smear examination. And the skin slit smear examination was positive in 3,319, which is 71.3% of the cases. So a study from India also reported seminal findings, with multibacillary leprosy being the most common type and type 1 lepra reaction being the most common type of lepra reaction. And the high percentage of multibacillary cases indicates late detection, which increases the risk of transmission and development of disabilities. Lepra reaction are the major cause of nerve damage and disability in leprosy patient. In our study also, 371 patients developed neuritis and 978 patients developed WHO grade 2 disability. Comprehensive management of leprosy patient, including early diagnosis and treatment of lepra reaction, is crucial to prevent the development of the debilitating outcomes such as disabilities. The high rate of positive skin slit smear in our study suggests a high bacterial load among the study population, which may contribute to the development of lepra reaction and other complications. So to conclude, despite our country Nepal's achievement of leprosy elimination as a public health problem already 1.5 decades back in 2010 AD, the persistence of new cases and the substantial burden of lepra reaction highlight the need for sustained public health efforts. Enhancing public awareness, improving health infrastructure, ensuring continuous training for healthcare workers are critical steps towards further reducing the incidence and impact of leprosy in Nepal. And the theme of today's our conference, maximizing benefits through responsible conduct of research. So more studies, more national level studies, prospective studies should be conducted among leprosy patients, as this study has proven it is an alarming sign in the post-elimination era of leprosy for our country, Nepal. So these are some of my references. I would like to acknowledge my parents, who are my biggest source of inspiration to be an early career investigator and researcher. And my mom happened to be here. Thank you so much to make it here today. And I'd also like to acknowledge my co-authors and co-investigators, Dr. Krishna Tamang, who is a medical director at Lalgod Leprosy Hospital and Service Center, Dhanusa, Nepal, and Ramesh Kumar Chaudhary, co-investigator, who is manager at Community Health and Development, Lalgod Leprosy Hospital and Service Center, Dhanusa. And obviously, I would like to acknowledge the Lalgod Leprosy Hospital Service Center for this research opportunity. And I'd also like to acknowledge all my faculties, all my professors, all my seniors, all my mentors throughout my research journey. So thank you so much.
Thank you.
Thank you.
Thank you for the nice presentation. I think we keep the question and answer at the end of after the sixth presentation. I would like to introduce the second speaker, and this is Dr. Yamani Chetri, who has a background of zoology, parasitology, and is from Central Department of Zoology, Tribhuvan University. And the title will be Investigation of Infections, Vaginitis, and UTI. Please, Dr. Yamani.
Thank you so much. Good morning, everyone. Honorable chairs and all the participants and the speakers. I'm very overwhelmed to get the opportunity to share my research with you all. And here's my topic, investigation of infectious vaginitis and urinary tract infection among women of reproductive age visiting Nepalganj Medical College, Teaching Hospital, Kohalpur, and their associated risk factors. Sorry. It's on. Okay. What? No, thank you. Sorry. Here's the overview of my presentation. First, from the introduction. Vaginitis is an inflammation of the vagina, and there are three most common vaginitis: bacterial vaginosis, which is caused due to the replacement of different microorganisms like Gardnerella vaginalis, bacterial species, genital mycoplasma, and anaerobic bacteria. And second one is vaginal candidiasis, which is caused by the overgrowth of fungal, mostly by Candida species. And another is Trichomonas trichomoniasis, which is caused by protozoan anaerobic protozoan parasite, that is Trichomonas vaginalis, and it is one of the sexually transmitted infection. And all of these three are mostly commonly characterized by characteristics such as vaginal discharge, itching, vaginal odor, dyspareunia, dysuria, vaginal erythema, and so on. What's the problem with this? Sorry. Yeah, difficult here. It's not working. Embarrassing. Fourth slide. Okay. Next one. Another is urinary tract infection, which is caused by different microorganisms, gram-negative and gram-positive bacteria. As you can see here, after gram staining, the pink one is gram-negative bacteria and the purple one is gram-positive bacteria. Next. For the sample size, I have calculated using Cochrane's equation and got 290 sample size for the research. Next. Sorry. For the objective of my study, the general objective was to evaluate the prevalence of trichomoniasis, candidiasis, and UTI among with the women, the reproductive age visiting gynecological outpatient department at Nepalganj Medical College Teaching Hospital. And the specific objective were to determine the prevalence of trichomoniasis and its associated risk factors. And the second one was to analyze the prevalence and associated risk factors of vaginal candidiasis. And the last one was to investigate the prevalence of urinary tract infection and the associated risk factors. For the inclusion and exclusion criteria, I had included the symptomatic patients with the symptoms such as dysuria, frequent urination, redness of the genital area, lower abdominal pain, profuse vaginal discharge, and so on. And for the exclusion criteria, I excluded the patient with catheter, serious disease, kidney problems, and those who were not willing to participate and provide informed consent. From the methods, for the study area, I have chosen Nepalganj Medical College Teaching Hospital, which is located at Kohalpur, Bankhe district, as it is hub hospital for all the western part of Western people. And this is a map showing the participants who were included, mostly from the Bankhe district, as the hospital is situated at Bankhe, along with Kailali, Dang, Surkhet, and other districts. For the sample collection and processing methods, prior sample collection, the patient's written consent, which is very necessary that we are talking about the ethics and all. And for that, written consent form was taken from the patient. And with the description of the research, and along that questionnaire survey was done in Nepali language so that it would be easy for them to understand. And then vaginal swab was collected in the presence of gynecologist using speculum examination. And for the midstream urine sample, container was provided to the patient, and the processing was done in the lab for wet mount, whiff test and smear preparation, gram stain and Giemsa stain. And the staining procedure was done in the lab using the procedure shown here. And for the midstream urine, the sample was inoculated into McConkey agar and blood agar plate, and those with a significant bacteriuria growth was perform gram staining to identify the gram-negative and gram-positive bacteria, and then after the identification of the gram-negative and gram-positive bacteria, it was further went for the biochemical test for the species identification. And for the biochemical test, gram-negative and gram-positive bacteria. For gram-negative bacteria, we used catalase, coagulase, oxidase, intolerant test, triple sugar iron agar test, methyl red, urease, and citrate. And for gram-positive bacteria, catalase, coagulase, mannitol agar test, and bile esculin test was done. And the ethical consideration, the first written questionnaire consent was taken from the patient and from the IRC, TU, IOST, Microbiology, Kirtipur, and from the hospitals, IRC, NGMC, TH, Kolpur, Bake. And here are the ethical approval. And for the statistical analysis, I used R core team and analyzed univariate and multivariate analysis was done. Can you play the video? Among the 290 samples, the 40 were positive, that is 13.79% of positive samples. Can you play the video? Here is a small video showing motile trichomonads. Okay, it's okay. Here you can see the small trichomonads. It's not visible. I'll go to the next. It's okay. Among the demographic variables, you can see occupation was statistically significant. Along with those, the working women, it was high among the working women, the prevalence, that is 24.56. And here you can see district-wise prevalence. Next. Okay. The ethnicity-wise prevalence, it was high among, in my research, I found it was high among Janjati and Dalit. Next. And among the ethnic groups in relation to economic status, it was high among high class Brahmin, Kshetri, Thakuri middle class, lower class of Janjati, and middle class of scheduled caste, that is Dalit. Next. And among the risk factor, those with multiple sexual partner, it was statistically significant and higher. And among the contraception use, those using hormonal contraception and IUD, and those who never use any type of contraception was seen a higher risk after doing the multivariate analysis. Next. Among the symptomatic factors, body temperature, lower abdominal pain, dyspareunia, and presence of discharge were statistically significant. Next. The color of discharge, as greenish discharge is the main characteristic of trichomoniasis, it was statistically significant. Along with the mixed discharge, it was higher among those with the mixed discharge too. And the foul smelling, it is also one of the prominent characteristic of the trichomoniasis. And I have also found with the strawberry cervix, as you can see in the figure, it was also statistically significant. Next. And another is candidiasis, 10.34% of prevalence was found in my research. And you can see pseudo-hyphae, and this is the boarding yeast. Next. And among the demographic variables, educational status was statistically significant. Those having college level education, it was higher among them. Next. And this is the district-wise prevalence. It was higher among other districts rather than in Baki. Next. And among the ethnicity, it was higher among Brahmin, Chetri Thakuri, Dalit, and then Janjati. Next. And among the economic status regarding with the ethnicity, it was higher among the middle class of each group. Next. And among the risk factors, those having had a less shower habit once a week, it was statistical. It was not statistically significant, but it was higher among those people. And the people using the wipes, such as not the clean wipes, they used cotton cloth that was reused. So I guess from there they had the infection of candidiasis. It was statistically significant. Next. And among the symptomatic lower abdominal pain, abnormal discharge, those having redness in the genital area and discharge color were statistically significant. As discharge color, the cordy white discharge is the prominent characteristic of vaginal candidiasis. It was seen higher among those, and also with the mixed discharge. Next. And among the UTI, 42 patients, that is 14.48% of prevalence was found. Among that, 57% were with the gram-negative, and the 43% were with the gram-positive bacteria. And here are some of the bacterial colony. Next. And among the different uropathogen, E. coli, Proteus vulgaris, Klebsiella species, Pseudomonas, Staphylococcus aureus were highly prevalent. Next. And among the demographic factors, none of the demographic factors were statistically significant. Next. And UTI was higher among the patient inhabited in Banke district, that is 18%. Next. Among the ethnic group, it was higher among Brahmins, Janjati, Dalit, and then Chetri Thakuri. Next. Among the economic status, the high class Brahmin, high class Chetri Thakuri, middle class Janjati, and high class scheduled caste, that is Dalit, were found to be highly prevalent in my study. Next. Among the risk factors, those with the groundwater as source of drinking water were statistically significant, and those with the use of the fiber was also one of the statistically significant factor in my study. Next. And another is bacterial vaginosis. I used both the criteria, Newton scores and Amsels criteria, and among that 65.86% and 66.21% was the prevalence, and it is not so different, as both are the same using the two criteria I used to diagnose the bacterial vaginosis. Next. And these are all the infections that I found, among which bacterial vaginosis is the highest, highly prevalent, followed by UTI, trichomoniasis, and the candidiasis. Next. The mixed infection was also found, as highest is the trichomoniasis and bacterial vaginosis in the same patient, and also the bacterial vaginosis and candidiasis, bacterial vaginosis and UTI, and in the same patient, 3 infections were also prevalent: bacterial vaginosis, UTI, and candidiasis, and also bacterial vaginosis, candidiasis, and trichomoniasis. And the list was the person with trichomoniasis and UTI. Next. And discussion, similar trends was also found in Central India, Iran, and Tanzania, along with the associated risk factors as age group 36 to 45, lower educational level, marital status as married, occupation, those having multiple partners, and the contraception methods. Next. And for the candidiasis, similar trends were also found in Ethiopia, South India, China, and the associated risk factors, the age less than 25 and higher than 46 year, college level education, marital status, that's widow, occupation, work and housewife, rural municipality residency, showering weekly, douching habit, cleaning genital with wipes, mostly with the reused cotton clothes. Next. And the UTI was also similar trends was seen in Libya. Okay. Libya, Ethiopia, Dharan, Nepal, and the associated risk factors are here. Next. bacterial vaginosis. Similar trends were seen in South India, at Pokhara. Next. As the bacterial vaginosis and candidiasis was also found in Uganda and Egypt and Burgons, and those with the three, bacterial vaginosis, trichomonasis and candidiasis, was also found in Uganda. Next. And I hadn't found any of the research articles that found the prevalence of all these. Next. For the recommendation, I recommended to have safe sexual practices with the trusted partners and use of contraception, and proper use of contraception to avoid the STIs, as STIs lead to the STDs, and for the intimate hygiene, and for the UTI, as it is transmitted by fecal contamination, special care should be taken to prevent these infection during defecation and other such practices. Next. These are some of the acknowledgement. I would like to acknowledge my supervisor, co-supervisor, the HOD of my department, the director of Nepalganj Medical College, HOD of the gynecological department, and the lab, and all the people who helped during my research. Next. These are some of the references. Thank you. Thank you so much.
We'll put the questions and answer session at the end as we talked earlier. Let me call upon the next presenter, Likhit Prasanna from Kasturba Medical College, India, on the title Off-Label Medicine Used in India. Dr. Prasanna, let's go ahead.
Yeah.
Your time is 10 minutes.
Yeah, thank you. Very good morning to the respected dignitaries and to my fellow speakers and the participants. Well, so I am Dr. Likhit from, I'm a junior resident from Kasturba Medical College, Manipal, in the southern state of India, that is Karnataka. So today I am presenting a topic on the off-label medicine use in India. Right. So overview of my presentation would be my study objectives, what exactly is an off-label drug, and methods, and the study design and the discussion. So, introduction to an off-label drug use. So what exactly is an off-label drug? So an off-label drug is that drug which is being used, which is being prescribed by a physician for any given condition which is not officially approved. So, but it's still been prescribed by the physicians for various reasons. It could be because of various reasons. The rationale behind my study here is to address the insights of the off-label prescribing and the ethical concerns of prescribing the off-label drugs. And the background of the off-label drug use is why exactly it's been prescribed by the physicians these days. Even though if it's not officially approved, but why is it prescribed? There could be a lack of alternative drugs, or it could be because of the physician's his or her own clinical experience, or any emerging evidence as such. The major concerns which raises here is the safety issues, that is a risk of adverse drug reactions, and efficacy which is uncertain. The significant challenges that we face here because there is lack of clear-cut guidelines, and also there is an insufficient incentives for the clinical trials in terms of pharmaceutical industries. These are some of the examples of the off-label drugs. If I could just point out of one of the drugs, that is gabapentin. So gabapentin is actually an anti-epileptic drug, and also it's used as a post-herpetic neuralgia. It's basically indicated in these conditions, but it's off-labelly used in terms of restless leg syndrome and insomnia, and also in diabetic neuropathy. So, speaking about the aims and objectives of my study, the primary aim is to describe the patterns and practices of the off-label drugs. The secondary is to understand and perceived safety and ethical concerns of the off-label drugs. Right. So this, coming to methods, The study was started after the approval of the Institutional Ethics Committee and the Central Clinical Trial Registration of India. And it is a cross-sectional study which is a digital survey with a sample size of 2,700, accounting for 10% withdrawals. Study settings is it's actually a interim analysis where I'm considering the data from 21st October to 4th November 2024, and the survey format is self-administered digital survey links and shared across various online platforms. So eligibility criteria is the Indian doctors more than 18 years, and the survey format which has been incomplete is considered as exclusion. It's excluded. So the statistical analysis here, the demographic data has been summarized using the descriptive statistics, and appropriate inferential statistics is used for the comparison, and the level of significance is set to be p less than 0.05. Right. So this is an interim analysis where I have forwarded a list of questionnaires to the responders. So I have the responders we have after fulfilling the eligibility criteria. It's around 100 responders, out of which the majority of them were 59% were female doctors, and the place of work distribution is around 65% were there in the private teaching hospitals, and the role distribution is most of them were residents or a PG trainee. And when asked the questionnaire about are they aware of off-label drugs, and most of them said yes, around 92% of them agreed that they are aware of off-label drugs being prescribed to patients. And what could be the common reasons of prescribing these off-label drugs? Out of which 50% have responded that they have not been prescribing the off-label drugs, whereas around 39% have said that it could be because of their own clinical experience, followed by non-availability of any alternate drugs, and followed by any case reports. And there was a questionnaire asked, after prescribing off-label drugs, did you experience or see any treatment failures after using these drugs? And most of them, around 39%, said that there was no treatment failure or seen, whereas around 28% agreed there was a treatment failure by using these off-label drugs. And the similar question regarding any adverse drug reactions, around 68% responded there was no adverse drug reactions when using these off-label drugs, and very least number that around 9% of the doctors agreed there is an adverse drug reaction when prescribed off-label drugs. And the frequency of informing to the institute ethics, around 28% have agreed they do inform the institute ethics, before prescribing off-label drug. And around the matter of concern here is around 25% of the respondents agreed that they don't inform the institute ethics before prescribing off-label drug. And what is the frequency of taking permission from the patient? Yes, doctors do prescribe off-label drugs very frequently, yes. But are they really informing patient before prescribing these drugs? So that is one of the questions we raised, because this leads us to a question of shared decision making between the doctor and the patient. And most of the doctors agreed, around 24%, they said that they never inform the patient before prescribing these off-label drugs, whereas 25% did agree, they do inform the patient before prescribing these off-label drugs. Coming to, should all current drugs be trialed in young population to avoid off-label drug use? Yes, around 71% agreed there should be a clinical trials in a younger population. Similar question was raised in all the ages, not just young, but should it be trialed in all the age groups? Yes, around 74% agreed, yes, there should be a clinical trials in all the age groups. And should government give incentives to perform clinical trials to avoid off-label prescribing? And around 74% of the respondents did agree that there should be the government should take appropriate steps to give incentives to these pharmaceutical companies. So there was a questioner raised what is the source of information about knowing these off-label drugs. So most of them did agree, around 64%. It's from medical journals, and around 52% have agreed. They get to know about these off-label drugs through conferences, various conferences, and online medical resource, pharma reps, and others. And the major concern regarding prescribing these off-label drugs had always been the safety, and has as we could see here, around 86% have agreed that safety is the major concern before prescribing these off-label drugs, followed by some ethical issues, efficacy, and there's no such concerns as such. All right. Coming to the discussion, which is ethical implication, there is a high use of these off-label drugs. Yes, around 50% of the respondents agreed that we do prescribe these drugs, but there are lack of clear-cut evidence, clear-cut guidelines before prescribing these drugs. And ethical and safety concern has always been a major issue. Around 28% have facing treatment failures, and 9% accounting for the adverse drug reactions. There is a lack of communication gap. And this one of our study stated by Day R.O. States the similar findings of where he signifies the importance of the shared doctor-patient consent. So this is very important that the patient should be well aware in prior if the drug which has been prescribed is an off-label drug, and the risk and the benefits which is associated with these drugs in prior. There is a need for oversight and evidence, which is a strong support for clinical trials has to be encouraged, and ethical frameworks to guide the safe off-label drugs has to be maintained. In conclusion, a high awareness is required, and 50% of them have been prescribing the off-label drugs in my study. And the top concerns that has been raised here is been safety and the efficacy of these off-label drugs. And the recommendations here is to enhance education and the safe practice of these off-label drugs, and support more and more researchers, and validate off-label uses. Encourage pharmaceutical company for the more incentives before these clinical trials of these off-label drugs, and improve patient communication and the consent policies. Right. Thank you.
Thank you. So we proceed with the next presenter, and this will be done online, a recorded session. And this is by Dr. Anil Kumar, who is an assistant professor in the Department of Pharmacy, Purbanchal University, Gurgaon, Nepal. Thank you. Yeah, so there will be a video. Is this a live or is it a recorded? Recorded, okay, thank you.
Let me start with introduction. Good morning, everyone. Honorable Chairperson, distinguished dignitaries, respected colleagues and audience. I am deeply honored and privileged to stand before you today to share our findings on the title level of adherence and prescribing pattern of glaucoma medications among the glaucoma patients in the Lamia Eye Hospital, Nepal, a cross-sectional study. Let me start with introduction. As we know, glaucoma is the chronic eye clinical conditions characterized by optic nerve damage and usually associated with the increase in intraocular pressures. About 80 million people have affected by the glaucoma disease around the world. So it is second leading cause of irreversible blindness in the eye in the world. 1.80% of the prevalence glaucoma have affected over the 40 years age of Nepalese people. The effectiveness of treatment heavily relies on the patient adherence to prescribed medication, and adherence to the medication is the crucial for the good clinical outcome and prevention of disease complications. With this background, this study was planned with the following objective: to determine the level of adherence and prescribing pattern of glaucoma medication and the glaucoma patient, to determine the association between the medication related factors and medication adherence. Now coming to the methodology, cross-sectional studies were used in this study, and the study was conducted in Lamhe Eye Hospital, Dang district, Nepal. The total population of these studies were 379. Newly diagnosed and follow-up glaucoma patients were selected by consecutive sampling technique. After completed sample size calculation, the calculated sample of populations were 379 newly diagnosed and follow-up glaucoma patients visited to the OPD department of Lamhe Eye Hospitals and were selected by using consecutive sampling technique. The patient as age 18 years and above, the having medical history of glaucoma undertaking glaucoma medication were included in this study, whereas the patient who had undergone laser or surgical glaucoma therapy and mentally impaired patients were excluded from this study. Now coming to the methodology of the data collection process study. First of all, ophthalmologists diagnosed the patient with glaucoma. The researchers selected newly and follow-up glaucoma patients visited in OPD department of Lamhe Eye Hospital and were selected by consecutive sampling technique. Before starting the data collection, the researcher took the written consent and patient informations who were participating in this study, and the researcher collect the demography informations and other information directly face-to-face interview with patient, and these all information were recorded in the data collection form. The level of adherence were identified by using Nepali versions of 8 items Moresky medication adherence scale, and the correct answers were scored as 0, whereas incorrect answers were scored as 1, and high medium adherence were scored value more than 6, and whereas the low adherence score value less than 6, and the demography and other information were entered in MS Excel and transferred into the SPSS. After analysis to perform mean and standard deviation, chi-square test, logistic regression, and the result part were interpreted in the table. Now coming to the result part. Altogether 379 patients were included in this study, and most of the glaucoma patients were 25.3% from the age of 61 to 70, and followed by 18.7% from the age of 51 to 60. Male and female were equally included in this study, and most of the patients visited to the Lamhe Eye Hospitals were 33.5% illiterate patient, followed by 32.2% for secondary schooling, and the Tharu's races glaucoma patients were 24.5%, followed by 20% Kshatri's races, and the majority of glaucoma patients were 32.2% housewife, and followed by 26% business, and most of the married glaucoma patients were 87.3% found in this study, and the primary open angular glaucoma were found 86%, and the normal visual acuity of glaucoma patients were 55.4%, and therapeutic classification of prescribed medication by the prescribers were 69.1% of therapeutic category of drugs ANS ANS, and followed by 21.1% for autopoietin related drugs. Therapeutic categories of common of anti-glaucoma medication prescribed by prescriber are 37.6% of timolol, 35.5% of bromidine, and followed by 21.5% bimatoprost. Patient response to the Moresky medication adherence scale 8 measured showed that 67.3% patients did not forgot to take their medications. 94% patients did not miss their medication for reasons other than forgetting, and around 99% of patients did not stop taking their medication without consulting the prescriber. Equal about half percent of half about 50% about half percent of the patient glaucoma patients sometimes forgot to bring along the medication when they travel and leave the home, and 98.2% patients continue the glaucoma medication even when they feel glaucoma is under control, and overall mean score of Moresky medication is medication range scale 8 is 6.79 plus minus 0.3 plus deviations, and these all parameters show that the good adherence in our studies. Bivariant analysis revealed that high and medium patient adherence score were considered as adherent, whereas low patient adherence score were considered as non-adherence, and about 100% of the patients of glaucoma patients from the age of 18 to 20 and found to be a good adherence, followed by 97.6% from 21 to 30 from age. And age wise we saw that where our p-value is less than 0.001 is so it is a statistical significance, and male and female genders were not, it was not shown statistical significance because where p-value is 0.367. Education level, higher education level where of glaucoma patients were 88%, followed by 80% secondary schooling patients, and here the p-value is less than 0.1 from the normal p-value, lesser from normal value, so it is a statistical significance. Unmarried patients of glaucoma patients were found to be 97.5.
No conclusion slides. Conclusion here. Conclusion slides.
eye hospital for multi-center. Conclusions: the level of adherence to the anti-glaucoma medication is suboptimal. Moreover, marital status and comorbidities are associated with better medication adherence, whereas the commonly prescribed anti-glaucoma drugs was beta blocker 37.6% and followed by alpha agonist 34.5%. Thank you.
Thank you, Dr. Saad, for your nice presentation. We'll put questions and answers at the last, and now we'll move into another presentation by Dr. Narendra Kumar Chaudhary from Nepal Orthopedic Hospital on the topic fasting versus carbohydrate loading to prepare for femur fracture surgery. Dr. Chaudhary.
Just I would like to check. Why? हुन्छ तर यो ब्याग पनि गइरहेको छैन तल गइरहेको छ ल हुन्छ Namaste and very good morning. I am Narendra Kumar Chaudhary from Nepal Orthopedic Hospital. Title page. Today on the auspicious occasion of 24th FERCAP International Conference, I am pleased to present on the topic fasting versus carbohydrate loading to prepare femur fracture surgery. So in the introduction section, femur fracture is most common among elder people that causes them bedridden for long time at hospital. Femur fracture is generally treated by surgical procedure, which is a challengeable task for clinician because of the different comorbidities present in most of the elder people. For surgery, patients are kept in long fasting according to the fasting protocol to avoid from pulmonary aspiration, and that leads to the patient to be in a catabolic state. Studies have revealed that catabolic state worsens the stress response and contribute to insulin resistance and hyperglycemia that lengthens the recovery period. Similarly, it leads to distress, confusion, instability, headache, dehydration, electrolyte imbalance, post-operative nausea, and vomiting. Next slide. So to overcome these types of challenges or issues, there is another concept that is called enhanced recovery after surgery, that is ERAS protocol. And in this protocol, patients are fed 100 grams and 50 grams of carbohydrates orally the night before and 2 hours before surgery respectively. That is called pre-operative carbohydrate loading. And there are many advantages of ERAS protocols. Few of them are there. That is, it improves muscle function, metabolic function, and wound healing. Similarly, it reduces insulin resistivity, post-operative protein and nitrogen loss, intraoperative core body temperature, length of post-operative stay at hospital, and of course, it reduces not only the financial cost to the patient, but also to the nation. Next slide. Hence, ERAS protocol is considered as novel as well as scientific approach in Europe, which is mostly practiced in general surgery, obstetrics, and gynecology. However, nutritional support is less prioritized, or it can be said that it is almost neglected in orthopedics for patients' fast post-operative recovery. This is the scenario of the developed countries in the world. Once we let's imagine what will be the scenario in the developing countries like in Nepal. Of course, we find that there is still the practice of prolonged fasting as a traditional anesthesia in Nepal. So the concern of our issue of this study was to assess the effect of perioperative carbohydrate loading on the improvement of postoperative pain, functional mobility, and the recovery rate among patients undergoing surgery for femur fracture management. Next. Our study was single-center, hospital-based, open-label, parallel group randomized controlled trial that started from August 2020 and completed in November 2021. And the study site was Nepal Orthopedic Hospital, Jorpadi, Kathmandu, Nepal, which is a charitable 100-bedded specialized orthopedic and trauma hospital. And the study population was the patients aged 50 years and above having a femur fracture planned for surgery. Similarly, those patients were excluded who had pre-existing diabetes type 1 or type 2, past carbohydrate intolerance, pathological fracture, or any suspected pathology, or any failure surgery or non-union cases. Next slide. Our sample size was 66. Total sample size was 66, 33 participants in each group. Next slide. And those participants were randomized into two groups, study groups and control group, into 1:1 ratio by using the computer-generated simple randomized technique. Next slide. In the control group, patients were kept in prolonged fasting from midnight to the next morning as in the existing, while in the intervention group, the patients were intervened with carbohydrate loading according to the ERAS protocol. And we used glucose D as a carbohydrate-rich drink of Nepali product. Next slide. Our primary outcomes were the postoperative pain that was assessed on first postoperative day with visual analog score, that is VAS score. Similarly, functional mobility were measured through the cumulative ability score on the first, second, and third postoperative day, and all of them were added. Modified Barthel index, that is activity of daily living, were used to find out the independence at the time of discharge from the hospital. And the secondary outcome was the serum albumin level that was measured before surgery and after surgery, and then the change in the albumin was evaluated. Next slide. Next slide. The predictor variables were the socio-demographic information, nutritional assessment, clinical parameters such as site and site of femur fracture, types of fracture, number of fractures, biochemical parameters like preoperative hemoglobin level, serum albumin level, intraoperative data like types of surgery, type of implants used, duration of surgery, amount of blood loss, blood transfusion, and adverse effect. Next slide. Data were entered in the EP data version 3 and brought into the Stata for the further statistical analysis. Distributed statistics was frequency, percentage, mean, and standard deviation. Similarly, chi-square test and student t-test were applied for the inferential statistics. Next slide. This was our flow chart of the study. Next slide. We took ethical approval from the Nepal Health Research Council, and then we made the clinical trial registry in the clinicaltrial.gov. Next slide. The socio-demographic features were comparable between both groups, that is control group and the study group. Next slide. Next. Also, the clinical parameters of the parameters were comparable between the control group and the study group. Next slide. We can see that the post-operative albumin level was found to be maintained in the study group than that of the control group. That means pre-operative carbohydrate loading tried to maintain the level of the serum albumin level. Next slide. Pre-operative carbohydrate loading reduced the pain score as well as the length of the hospital stay after surgery in the study group than that of the control group. Similarly, it increases the value of the CAS score and modified Barthel index that signifies the physical activity. Next slide. In reality, pre-operative carbohydrate loading has no adverse effect. However, we found 2 participants to be experienced with hypoglycemia during surgery, and the reason behind may be multifactorial and other modifiers concerned with its homeostasis. Next slide. Similarly, in the case of the pain reduction, preoperative carbohydrate loading significantly reduced postoperative pain, and the reason behind this is that the preoperative carbohydrate loading reduces different types of inflammatory markers such as C-reactive protein, that is CRP, and neutrophil lymphocyte ratio. Obviously, inflammation is the underlying origin of all pain. Besides this, dietary intake enhances nervous, immune, and endocrine nervous system, which has ultimately impact on the pain experiences. Next slide. Similarly, functional mobility were found to be higher value in the case of the study group than that of the control group. It is because of the factor that preoperative carbohydrate loading improves the carbohydrate uptake, utilization, storage, protein metabolism, and hence leads to a 50% reduction in the loss of lean body mass. Similarly, it stores glycogen in the muscle, hence prevents the loss of lower limb mass. Modified Barthel index, activities of daily living index score was also found to be higher in the study group than that of the control group. Next slide. Our secondary outcome was the serum albumin level, which was found to be maintained in the study group. It is because of the factor that the preoperative carbohydrate loading facilitates the perioperative insulin production, which promotes or maintains the synthesis of the serum albumin. Similarly, if the serum albumin is lower, the low serum albumin level leads to the poor prognosis, delaying the clinical outcome.
So, just 2 minutes, you have to wrap.
So this study concludes that the preoperative carbohydrate loading reduces the postoperative pain, it enhances the ambulatory function, it shortens the hospital stay, and this study recommends for the larger trials with a higher sample size for stronger evidence. And further study can be conducted by using beverage as a preoperative drink that contains carbohydrate, fat, protein, and other micronutrients to acquire additional better postoperative outcomes. Next slide. So our study had few limitations. Next slide. I would like to acknowledge Nepal Health Research Council who provided me the provincial research grant for this research. Next slide. This is the reference. Next slide. This is present information. Next slide. Thank you for your attention.
Thank you for the presentation. Our final presentation will be pain management of cancer patients, and this is by Mrs. Mijala Bajrachaira, who has a background of pharmacy and who is currently associate professor and also the head of Department of Pharmacy in Manmohan Memorial Institute of Health Sciences, Soalti Mode, Kathmandu, Nepal. Yes.
Thank you. Namaste and very good morning to the respected chairs and all the distinguished guests present here. I am Mijala Bajrachaira, currently working as Head of Pharmacy Department at Manmohan Memorial Institute of Health Sciences, Kathmandu. And I feel really honored and privileged to present at 24th FERCAP International Conference. Okay, next one. Slide. Okay.
And try the clicker. If not, then you just ask them to do next. The slides is not out yet. Yes.
Okay, the topic of my research is pain management of cancer patients, and my research team includes myself and my student Arjun Bhul and Anjali Malik. Okay, pain is the most common and devastating symptom of the cancer patients that affects not only the quality of life of the patient but also affects the quality of life of the family members and the caregivers. The prevalence of cancer-related pain ranges from 14 to 100%, and incidence of pain in the cancer occur in all stages, indicating 53% in the all stages, 64% in advanced stages, and 33% in cured patients. So this Percentage of prevalence shows that pain is problem in cancer patients, whether they are newly diagnosed, whether they are under the chemotherapy, or they are cancer survivors. So pain management is essential part of the oncology care. Next. Back. Okay. The main objective of our study was to study the approaches made for the management of the cancer-related pain, and the specific objectives were to study the demography of the cancer patients, to study the types and stages of cancer, to assess the severity of pain experienced by cancer patients, to study drugs used for the pain management of cancer patients, and to identify non-pharmacological approaches used for the pain management of the cancer patients. And regarding methods and methodology, this was the prospective, observational, descriptive, quantitative study. The study was done at Bhaktapur Cancer Hospital, located at Byasi, Bhaktapur, Nepal. The sample size was 274, and data was collected for 5 months from August 2022 to December 2022. And the data were collected through the face-to-face interview using structured questionnaire with the patients or patient caretaker, and reviewing the in-patient medical records of the interviewed patients. Questionnaires were prepared by using the National Comprehensive Cancer Network guidelines and brief pain inventory as a reference for the pain assessment. Data collected as per the questionnaire was coded on the SPSS 26 version, and descriptive statistics was used for the interpretation of the data. And regarding result, the sample size was 274, and in our research, male patients were slightly higher in number than the female patients. And regarding the age group, majority of the patients were in the age group of 60 to 69. And regarding the religion, most of the patients were of the Hindu religion. Regarding types, about 28% of the cancer patients were of the lung cancer type, followed by the head and neck, ovarian, and the uterine cancer. And regarding the stages of cancer, around 38% of the cancer patients did not know about their stage, and about 34% of the cancer patients were on the 4th stage. And regarding the site of the pain, most of the patients complained of the stomach pain, followed by the pain at the chest and the pelvic site. And when we ask about the when do you feel the pain mostly, most of the patients answer that they feel pain at every time of the day, and some also say that they feel pain worse when they are walking, sitting, or breathing. And about the pain assessment, the mean score of the worst pain was reported to be 7.5, and the mean score of the pain after medication was recorded to be 3.05. And about the severity of the pain, before medication, most of the patients complained of the severe pain. That is 65% of the patients complained of severe pain. And after medication, the majority of the patients, that is 68% of the patients, complained of the mild pain, and only 4% of the patients said that they have no pain after the pain medication. So regarding the pharmacological management, we observed that Bhaktapur Cancer Hospital has been using WHO analgesic ladder for the treatment of the cancer pain. In this ladder, in step 1, non-opioids are being used. In step 2, weak opioids are being used. And in step 3, strong opioids. And in step 4, adjuvant drugs have been used. And in the step 1, in the non-opioids, acetaminophen is being mostly frequently prescribed for the patients, followed by hyoscine butyl bromide and ketorolac. And in the weak opioid category, tramadol hydrochloride is being mostly prescribed for the patients, followed by combination of acetaminophen and tramadol hydrochloride. And in the strong opioids, morphine is being mostly prescribed to the patients. About 30% of the patients has been prescribed with the morphine, followed by the fentanyl. And regarding the adjuvant drugs, different corticosteroids like dexamethasone, hydrocortisone, and other drugs like gabapentin, olanzapine has also been prescribed to the cancer patients. Okay, and this is the average dose of the drugs used for the pain management of the cancer patients. And about the non-pharmacological methods, we observed that only the palliative ward of the Bhaktapur Hospital use the non-pharmacological methods, and they have been using different non-pharmacological methods like music therapy, warm compression, massage, and others. So regarding discussion, we say that cancer pain management remains suboptimal, and there may be different barriers due to which the cancer pain management remains suboptimal, and different barriers are to be identified and overcome for the effective management of the cancer-related pain. And it requires the multidisciplinary approach that includes the medication, supportive care, psychological intervention, and other complementary treatments like the educational intervention and other necessary supportive care for the cancer patients. So regarding the conclusion, despite the development of the novel analgesics and the pain management guidelines, cancer pain remains undermanaged, and effective pain management is vital for improving the quality of life of the cancer patients, and it requires the multidisciplinary approach from the different interprofessional teams, and by properly mixing the pharmacological and non-pharmacological methods, we can better manage cancer pain in the cancer patients. Okay, thank you for the kind attention.
Thank you for the short and sweet presentation. Okay, we open the questions, the floor. Any questions from the rest of you? The presenters are so eager to answer questions. Please ask them questions. You have more time, less people, and have high probability to ask questions. Maybe I can start the question. Can I do that as a chairperson? I just want to ask about this vaginitis, just now the presentation. How do you actually, because this is a very sensitive issue and it's quite private questions, can you just share with us on how do you ask these patients the process of informed consent? And I noticed there's a lot of questions on all this, whether you use cloth, whether the practice, the habit. How do you maintain maintain the privacy and confidentiality of these answers?
Thank you for the question. It's okay. Okay. Thank you for the question. Firstly, I went on the field for 6 months prior in the gynecological outpatient department with along all the doctors, PG, and the HOD, and along with them during the patients when they come to visit the gynecologist, along them I sat as it is a private area, the patients, as we treat one by one and we take the clinical history. And first I described about all the about my research, as I have a consent form, and it has been clearly mentioned everything, that everything will be private and all things will be hidden. And if they agreed, then only I took them as a participant of my research, and along that the PG doctors, I took all the questions.
So there's a private room and the questions are very directed to them.
Yes.
Yeah, it's very important because you don't want the other people in that room to know whether this person has some vaginal infection. And another question, while waiting for the rest to ask. Yes, come, please.
OBGYN, so I know exactly, when we do to perform all that, treatment, have to go to the private room, exactly everywhere in the world for the, yes, so I know that. And then if she's the one that may be as a, like a guest to that private treatment, so she introduced her and patient say yes, so we can go on. So this is absolutely for the confidentiality.
Yeah, it took me 6 months to collect the 290 patients' data. So.
Well done.
Thank you.
And another question. Okay, while waiting for the rest to have more questions, maybe there's one more question for me to you. Is that possible? Sorry. I noticed that you are looking at different ethnicity and different, what do you call them? Some Brahmin.
Ethnicity.
Ethnicity?
Yes.
How do you think by looking at different ethnicity will be having some impact to your results? Is there any difference in the habit? I'm not clear on how does this analysis of ethnicity will actually give you the information on the risk of infection. Can you explain on that?
There are different ethnicity groups in Nepal, so I try to get if there's any differences, as the habits are different, like fooding, lodging. The habits are different of a different economic status group and the ethnic group. So I just thought, as I've seen in other researches, they try to just distinguish that thing that in which group it might be higher. So a detailed study can be done in the further days. It might be impactful in future that in a certain community, if there's higher prevalence, or we can just to eradicate from that community, so that
I'm not sure. I was told there's 100 tribes in Nepal.
Yeah,
I'm not sure whether there's some difference in how the habit among the ladies in different tribes. But because of the Brahmin has a very small number of participants, it looks like the Brahmin has a higher risk of infection compared to the rest because the rest of the tribes are more of middle. Yeah, but I think in terms of ethics, in terms of, I personally think that there must be a good reason on how do you do this and to differentiate between ethnicity. That should be a good reason, or else it will just give a false alarm without unnecessary extra information. Thank you. Any more questions? I'm waiting for the rest to ask questions. Yes, thank you. Can we have the mic there?
Thank you for this opportunity. I do not have any specific question to a specific presenter, but as a theme of this session is an ethical issue in biomedical research. It's a very general question, open question to all the presenters. Have you faced any specific or very interesting ethical issues during your data collection? If yes, please share with us.
Yes. Thank you for we should actually focus on the topics. Thank you for the question. I will allow that question to be answered by each one of you. And in 1 minute, can you just tell us whether you have any ethical challenges we give you the rest first lah. You ask something. How can we attack you so many times?
Thank you so much for the question, sir. So my topic was retrospective study of profile of leprosy patient. And during my research period, the thing that I was to convince the medical director from Lalgod Leprosy Hospital, because I am an intern doctor at Triveni University, and I was posted in health service management field program during my 4th year of MBBS for about a month. And during that time, I was inspired to do research in among leprosy patients, because I saw a research gap because it has already been eradicated.
Can I just interrupt you? Maybe you just focus on the ethical challenges, since the question is on ethical challenges while you're doing that. We know what is the gap, we know from the presentation. You just share with us on the ethical challenges you face during the conduct of the study.
To be honest, I did not face any particular ethical challenge, because the medical director at that center were very cooperative. My professors were very cooperative, and NHRC team was also very cooperative for me to get an ethical approval. So I did not face any kind of specific challenges. Thank you so much.
Do you have any ethical challenges? Anything you want to add, maybe?
Okay. Thank you for the question. Our research was among the cancer patients, and while doing survey, while doing question answer session, we feel difficulty in connecting with the cancer patients, because they have so many problems, they were suffering so much. So some of the caregivers also hesitate to clearly open in this situation. So not the ethical consideration, but there was certain type of hesitation or certain type of limitation among the patients.
Yeah,
so
I agree. When you are in pain and that is stage 4, I don't think that patients will will be freely telling you and answering questions.
They were not feeling happy, or they were some like agitation included in that. So
and of course, we don't include them if they are in not a very good mental state. Thank you. We have you, yes. I'm very impressed with you. You know, I was looking at your CV. You are a radiographer, but you have so many years in nutrition. So you look like more of a nutritionist rather than a radiographer. I was looking at oh my God. Okay, do you have any challenges?
Thank you for this question. I would like to share my experiences that I faced during this research. First thing that I faced the problem is the ethical approval, because this is clinical trial and it has to be approved only from the NHRC. That is the first problem for the researcher. Ethical approval should be received only from the NHRC if the clinical trial, if there is clinical trial. That is first problem that we face, because NHRC there is a long process to get the ethical approval. And this was the provincial research grant. That from the grant section, time to time they call me for the first ethical approval, but ethical approval section has long process. That is one thing. Second thing is, this study was very new in the context of Nepal, that is preoperative carbohydrate loading. Generally, patients are kept in almost 10 to 20 hours before the surgery due to the institutional setup. Yeah. Clinically, it is defined at only 6 to 8 hours, but practically it is not feasible, because after 12 p.m., patients are not allowed. So there is no chance to take something early. Another thing. Second thing, I feel that the patients are very difficult to convince them, because we are not clinician. Clinician, whatever they say, patient trust, patient believes. But we are not clinician.
Do you involve clinicians in your
No, I'm not that doctor. So that was another problem for the non-clinician. Third thing is that I faced problem, that is, first of all, I had to convince anesthetists, surgeons, nursing staff, because they were not ready to feed 2 hours before the surgery. That was another. Thank you.
Yeah, sure.
I have a supplementary question to him on the first answer.
Yes. Please,
go ahead.
Okay, because according to the ICHGCP, the clinical trial, this is a clinical trial, this is intervention, have to be done by the experienced doctor. Is it according to GCP, right? So I think it's against the kind of regulation if the radiographer to be the...
No, he has a very many years in nutrition.
No, but this has to be clinical.
Yeah.
It has to be a doctor to perform the clinical trial according to ICHGCP. So
I think probably we don't question that yet at this moment, because it has been approved by the Nepal Health Council, Research Council.
It depends on the Nepal regulation.
But my opinion is, I would prefer to have a multidisciplinary involvement in this.
Right.
And there should be a clinician, I think, will be helping you. The anesthetist, it is a very good study. Yeah, I'm an endocrinologist, so I'm actually very interested in your study. But to make it more feasible, you need to have involvement of other people. And is it in your part of your team?
In the team.
Why
are you having all the challenges alone?
Well?
They must be helping you.
Because this is
so there's our clinicians. They are
but the team has orthopedics, surgeon,
orthopedic, anesthetists,
anyway, because it's really dangerous. You have a lot of side effects. You have
he has
a lot of pain.
As a chairperson, I convince you that he has all the respective persons in the team. Well done. Okay.
I have some supplementary questions, and probably Chaudharyji, you should clear that it is not your individual research, it's an institutional research, and you have worked in a team as a PI. Is that correct?
Yeah.
Okay.
Well
As
done.
a team, still you face some challenges. That's what you explore. So I would like to explore a little more. As you mentioned, the first challenge is getting ethical approval from Nepal Health Research Council because this is a clinical trial. Can you explain a little bit on the steps? Which steps are you stuck up and how NHRC could help you and the future researchers to get through? It should be clear on the which steps where, on submission or on documentation or where. So let's try to understand that for GCP guideline, you need some people to really work on clinical areas. You need some people to work on those areas which have experience and degrees. So where did you get those difficulties? On submission, on evaluation, on the response, or how? What is exactly the problem? Can you quantify?
I could not face the problem in the submission system. Submission system is perfect, but the reviewer's feedback takes almost 15 days, 1 month. That is delay. That makes the delay.
Okay. Was the response negative or
No, response was
difficult to answer? What is the problem? Because reviewers need to review your protocol. It takes time. Research is not such that you do an emergency operation. It's a planned thing. You need to be prepared on your time to get somebody, review the protocol, give you feedback on what are the ethical issues which you need to address. Did you get any difficulties in that? It is only timeline for 15 days or so. Any protocol which is submitted to NHRC ERB as a past chairperson of the ERB, it's 1 month time which normally takes. And if the response is delayed, it may be delayed. So where are the problems? So I need to know and I need to pass it to the current authorities so that this could be facilitated.
Okay, I think probably I'm the neutral person here. I will actually say that probably I think you need to discuss it further outside of this session. I understand your frustration as investigator. I also face that in the chair of the Malaysia Ethics Committee. But I agree with you very much because there's a lot of things that there's miscommunication and misunderstanding. The PIs are waiting for the approval, and our part in the ethics, there are a lot of things that we look at, and these are the challenges between us. Yeah, we are also PI on and off, but thank you very much for the presentation and the effort of doing a randomized control trial. One last burning question to yes, gentlemen. I actually a bit unclear on the use of off-label medication in your country.
Right.
Because in Malaysia, when we have to use off-label medication, we need to ask the Director General of Health whether we are allowed to do that.
Right.
And if only by the signature of the DG, the Director General of Health, we can actually initiate the medication as off-label medication. And I noticed your presentation, there's not really a approval. How do you explain that in terms of the ethics of giving this information? And you rightly say that there's no communication with the patient and we are not sure of the risk to the patient. Can you explain that?
Yes. So they do prescribe off-label drugs in India. Could be reasons because what happens usually maybe because of the lack of clinical trials or the expenses of the drugs to be approved for the indications which has not been indicated in a product PI product information. So often physicians do prescribe these drugs though it has not been approved. For say recently what we could see is one of the drug for say when we talk about OHA's high diabetic medication, semaglutide, right, which was not, which was off-labelly prescribed for weight loss management previously, right? But now it's officially approved for weight loss management. So
Is it in your list of medications can be used in India?
yes, yes, it is list. It can be used now. It's officially approved right now. So based on the demand of the patient, or could be the influence of any social media. So like this, for example, the semaglutide itself, it was very popular among the the models and to be used.
He's giving examples in endocrinology,
Yes,
so I
because
can
it's more
understand it
relevant.
better.
It's more relevant. So that is officially based
Yeah.
on the demand, and it's officially
Yeah,
approved
that is
now.
the one who which is I mean there's indication and it's in your
It
list.
is indication now.
So I was looking it as results that probably will be a good results to your stakeholder.
Yeah.
Because you are actually telling people, I mean, from the presentation, that there are so many physicians that are using it as off-label without
Yes.
any approval. So how do you think that your results can be actually be useful to probably change the policy and some practices that has been done in your country?
Definitely, yes. It will be useful to prescribe these drugs for the indications where the physicians has been prescribing these medicines. It only needs, as per one of my questionnaire, to increase the incentives for the pharmaceutical companies. So if these incentives has been given for the pharmaceutical company, then the pharmaceutical companies will, take a stand in manufacturing these medicines for the new indications. So in that way, these medications can be approved for, for
Thank
the
you, thank you.
indications.
Yeah, I let the co-chair. Any question?
Yeah, a little bit. Because if you say that, is it over? Right?
Yeah.
For the off-label,
Yeah.
as according to the ICSTCP or whatever that's supposed to be, if you want to do the trial on that off-label, that need to be classified as phase 3. So you have to be approved by the EC as well as the FDA.
Yes.
Will control all that before you can, do going on the study. And if you get a good result, it's going to be good because it's all, well prepared.
Right.
If you consider just off-label drug,
Yes.
because it costs many kinds of label drug, can be
Yes.
dangerous, can be
Yes.
very useful.
Yes.
But in terms of that, your paper is look like the counter drug medicine that everybody can prescribe that, right?
Exactly. Yeah.
So if you want to do something more, I think that you have to go for the clinical
Trials.
phase 3.
Yes.
For this, got indications whatsoever, and then the result is going to be good. Or maybe not, I don't know, but it's got to be
Right.
true.
But maybe a bit of addition. When it's off-label, the definition that I know usually is actually available evidence. There's clinical evidence. The only
Yes.
thing that is not in our list of medications in the country.
Yes.
There's few reasons in Malaysia, sometimes because of the cost. So it's not in the list of medication. But when we use off-label, they are definitely have clinical evidence. There's evidence-based medicine. So there's no doubt of using it, but you are not following the country's guideline. That is a concern.
Yeah.
But my personal view is it's very difficult for you to convince a pharmaceutical company to do a proper randomized control trial because it costs a lot of money.
So that is where the government should take initiative, I feel.
Yeah, thank you. My co-chairperson will wrap it up.
Thank you, Naveen, for this very interesting discussion. First of all, I would like to thank all 6 presenters who have presented their findings very efficiently. Some of the points which have come up in discussion, but few of the points which might be interesting is, as this is a FERCAP conference, it's better to concentrate on ethical issues, not only scientific. Although scientific is the first importance to become ethical. So challenges like taking a consent, taking the photograph of patients, I could see some of the presenters have presented some hospitals, patients, photographs and others. I believe you have taken consent to do that, and in doing that also you have to omit some of the spaces so that the patients are not recognized. I hope you will do this in the coming days, and very interesting to know the findings which you have brought in, and probably this will give you more spaces in the days so that the research which we all do will be ethically good, and we can conduct research very ethically. Thank you for this session. I would like to thank NHRC, 24th FERCAP for giving us this opportunity, and all the presenters who have presented their findings so that others will know what are the challenges and how we could go further in the days to come. And the participants who have actively participated with their points in the session. Thank you all. I now pass on to the Master of Ceremony for further. Thank you.
Thank you, sir, for your closing remarks. Thank you to all the presenters for their valuable and engaging contribution. Your work has significantly enriched our understanding of ethical issues in biomedical research. I now would like to invite the presenters on the stage to receive a token of appreciation, and kindly request our session chairs to present the token of appreciation to the presenters. Please join me in applauding them as they come to the stage. So please. Dr. Subeksha Shaurya Shah. Miss Yamini Chetri. Dr. Likhit Prasanna. Mr. Narendra Kumar Chaudhary. Miss Mijala Bajracharya. I would like to request all the presenters and chairs to be on stage for group photo. Please come on stage for group photo. Thank you. Moving ahead, I would like to invite Professor Madhusudan Subedi to present token of appreciation to our session chairs. Thank you, sir. As we close this session, I once again thank our presenter, esteemed chairs, and all participants for their active engagement and contribution. We will now take a short break before the next session. Please return to the conference hall by 11 a.m. to continue with the day's program. Thank you and enjoy the break.
For you. Good morning and a warm welcome to all of you. It is truly an honor to have so many brilliant minds gathered here today, united by our sheer passion towards responsible conduct of research. We are delighted to have such a diverse and accomplished group of professionals. Myself, Elina Khatri, will be hosting this session entitled Ethical Issues in Special Topics in Health Research. Now, may I take this opportunity to introduce our esteemed chairs for the session, who will guide us through what promises to be an engaging and thought-provoking discussion. It is my great pleasure to welcome our esteemed chairs, Dr. Afonpiam Ketupenia and Professor Dr. Sudha Vasnet. I heartily welcome you on our dais. Please offer a big round of applause to our honored chairs. Now introducing Dr. Ketupenia. She is specialized in women health and represents Center Research Ethics Committee of FERCAP. Likewise, Dr. Bosnet, she is a professor at Department of Child Health, Tribhuvan University, Institute of Medicine, Kathmandu. Currently, she is a member of IRC Accreditation Subcommittee and a former Ethical Review Board member at NHRC. With this, now I'd like to hand over this session to our chairs. Over to you, chairs. Thank you.
the first speaker is Ms. Richand Shrestha. Mr. Richand Shrestha. So he's a PhD scholar in the School of Education at Kathmandu University, and he has been working on pro-environmental behavior among adolescents as a research fellow. He's also visiting faculty, and he is also a passionate academician and teaches subjects like economics of sustainability and enterprise, research methods, and especially quantitative research methods around academic institutions in the Kathmandu Valley, and has been involved a lot in research and has also published in many journals. Thank you, Mr. Richand, and we look forward to your presentation.
Thank you very much, yes. So let me start my presentation. Okay. Okay, no worries. Okay, thank you. Actually, my voice is so loud, so maybe I don't require the mic. Anyway, I'll try my best. Thank you, Chair, once again. And good morning, everyone. And namaste, and welcome to this presentation. So before I start my presentations, I hope like everyone is enjoying or acquiring the knowledge on the issue of ethics and research. I will also like to thank NHRC for providing this wonderful opportunity where we can share our knowledge, and at the same time we are also able to acquire the knowledge from other researchers or other delegates. So for that I am really thankful on that. So on today's, I have been provided to talk on the special topics on ethics on the health research, and today on that issue I am presenting on the topics you can see on the slide: the trend of ethics on the research of pro-environmental behavior, a systematic literature review using PRISMA. And for the first question, as the chair has suggested me to talk about the ethical issues, so probably the first ethical issues on this research might be the choice of databases. I have only chosen, I am also going to talk about in this methodology, I have only chosen the Scopus and Web of Science indexed articles. So probably there might be other grey literatures, government documents, which I have not included in my study. So that might create some kind of bias. So that is what I consider ethical issues while performing this research. So talking about that, so yeah, pointer, where is this? Okay, sorry, there is no pointer. Okay, तपाईले नै गर्दिदा पनि हुन्छ. Yeah. Okay. Okay, yeah, okay. So, we cannot deny the fact that the time we are living right now, because of the greediness of human societies, we have been degrading the climate. So, the climate crisis is a pressing global issue with negative consequences for the environment, and it is affecting the human society as well. Because of our greediness, we have been now being the victimized because of the climate crisis, and different researchers have suggested like different kind of mental and health issues related with climate crisis issues. So one of the idea to mitigate the climate crisis might be the pro-environmental behavior. So now the question is, what is pro-environmental behavior? So any behavior or act that is intended to reduce the impact on the climate crisis or negative impact on the climate crisis, then that behavior is known as pro-environmental behavior. And since I believe that instead of talking about the big things, I think if we act individually, then we can create a sustainable environment. So it is very important for individual to behave positively towards environment, and mitigating the climate crisis is also one of the major agenda of 2030 Sustainable Development Goal, right? And there are different behavioral changes rooted in ethics, right? There are different factors that contribute in the pro-environmental behavior, and among them, one of the major concerns that is not being much researched is the ethical consideration on pro-environmental behavior. And I think it is very, very important to have a discourse on ethical issues on pro-environmental behavior. So, with this consideration, I tried to find some literatures if there is any discourse on ethical issues, ethical influence on pro-environmental behavior, but I found that there are limited studies that have consolidated the ethical discourse on pro-environmental behavior. So, my main objective of this study is to conduct a systematic literature review to consolidate that dispersed discourse on the influence of ethics on pro-environmental behavior. Okay, so methodology, what I use is, in this research, I use the systematic literature review. Am I audible, right? So, should not be a problem. So, in order to perform the systematic literature review, I use the PRISMA framework, that is preferred reporting item for systematic review and meta-analysis. And as I said earlier, in order to conduct this type of research, there are 4 major things. First thing is the choice of the databases. And in that case, I use the Scopus and Web of Science that was published between January 1, 2010 and April 20, 2024. And I also selected English language as one of the criteria. And of course, the articles needs to be open access. So these are some of the requirements. No? Yeah, okay, it's not changing yet. Okay, and another important thing is the choice of the keywords. So there are different keywords that I choose for ethics and also for pro-environmental behavior. For example, for ethics I choose morality, integrity, and for environment behavior I use like pro-environment behavior, environment-friendly behavior, responsible behavior. Okay, thank you. Thank you then. So in this way, I choose like different keywords in order to source the literatures, and based on this, okay, so this is the overall framework. So I'm sorry for that. I don't know why it's not showing properly. Anyway, while going through the process, there I identified like 52 articles, like which includes the including the inclusion and exclusion criteria. So final articles are around 52 articles that has been talking about the ethics on pro-environmental behavior, and based on this, so these are my results and findings. And after going through those 52 articles, I found that there are like 4 major subject area that has been being discoursed in pro-environmental behavior in terms of ethics. They are morality, ethics, pro-social behavior or benefiting others, and corporate social responsibility. And under morality, there is moral norms. So society is impacting individuals. So social norms is very, very important. Similarly, like the behavior from the friends and the past behavior is also important. Likewise, when we talk about the ethics, I think it is very important. Yeah. So it is very important that business houses needs to be come forward. So they need to create a good environment, and ethical leadership is very, very important while creating pro-environmental behavior. Likewise, altruistic behavior. That means we always need to think about others. Others means here environment or animals. So if we have like altruistic behavior, then that also guide us to the pro-environmental behavior. So discussion. So as my findings suggest, many other researchers have also suggested about moral norms, ethical leadership, altruistic behavior, and CSR as a major discourse area in the field of pro-environmental behavior. And I think it is very, very important for different stakeholders to act towards creating a better environment, because we are the part of the environment. If environment is degraded, and that means it is that will victimize us. So, however, there are certain limitations. Like as I said earlier, I have only used 2 databases, and in terms of analysis, I only use the social and psychological field. There might be other fields as well. And this study was time bound. I did not include the story before 2010 and after April 20, 2024. And also there might be some limited keywords. There might be other keywords that could have been integrated in this study. So in conclusion, as I said, climate crisis, I think, has a negative consequences for environment and for society. And in order to create a sustainable environment, I think pro-environmental behavior from the individual level is very, very necessary. For that, different stakeholders has to come forward. Either it is society, or it's business leaders, or educational institutions. Everybody has to come forward in order to make ethical values towards protecting the environment. And I request everyone here as well, we have to behave from ourselves, from inner ourselves. We have to act for our environment, because if environment is degraded, that will degrade our health, including both mental and physical health. And my study might be helpful for business organizations. They can create a good ethical leadership for protecting the environment. Similarly, educational institution, it might be helpful to create the education system that includes the ethical values. Likewise, individuals, with the findings, individuals can behave positively towards environment. And similarly, future researchers, there has not been much done research on these issues. So future researchers can think about the empirical research on influence of ethical values on pro-environmental behavior. So these are some of my conclusions, and these are my references that I used. Where is that? Okay, these are my references, and I would like to end my presentation here. Thank you very much.
Topic. And then I think we move over. The second presenter is going to be online, right? Let's start with the second one. Nothing. You can ask a question. It was not much. But nothing coming out. Do you have the second presenter? The second one is online.
Afternoon. I will be discussing the topic ethical issues in forensic genetic testing. It's defined as the branch of science that applies genetic analysis to criminal investigations, identification of human remains, and resolving legal disputes. DNA profiling compares genetic material from biological samples collected from crime scenes, victims, and suspects to establish connections or confirm identities. It plays a key role in cases of paternity, sexual assault, missing persons, human trafficking, investigations, and disaster victim identification. Technological advances have made this field highly reliable, although ethical and privacy concerns are important considerations. In the Philippines, there are 3 local forensic DNA labs. 2 are independently run by law enforcement agencies, namely the National Bureau of Investigations, or NBI, established in 1998, and the Philippine National Police, or PNP, established in the year 2000. The DNA analysis lab, which I head, was established in 1996 as part of the University of the Philippines. It is the only university-based DNA laboratory, and thus is more focused on research and training. At times, our laboratory may be ordered by a Philippine court to assist other laboratories in criminal investigations. Crime scenes are commonly limited in quantity. Hence, protocols must first be tested using other biological samples under conditions that have been simulated as close to the crime as possible. This work is part of the research trusts of our lab, wherein we work on different sample types, such as bone and teeth commonly submitted for human remains identification. We have also been working on establishing a workflow for handling DNA in complex mixture cases submitted during a sexual assault investigation. Cases involving incest rape, multiple perpetrators, and minor victims are quite difficult to handle, hence the need for careful validation of methodologies. Now, we need to differentiate crime scene or evidence samples and reference samples. Crime scene samples are biological material collected from the location of an incident, such as hair, tissues, and body fluid, blood, semen, saliva, urine, or sweat. These samples are often unidentified and used to establish links between suspects, victims, and the crime. Reference samples, on the other hand, are known samples collected from specific individuals, such as suspects, victims, or family members. This include buccal swabs or blood samples, which serve as a comparison to crime scene evidence. This would be to confirm or exclude potential matches. Both types of samples are essential in DNA analysis. This slide shows the DNA analysis workflow commonly used to generate the sample genotype via fragment analysis or DNA sequencing. Ethical concerns have been raised in the sample collection procedures performed before the workflow, as well as the handling, use, access, and archiving of DNA profiles and sequences done at the end of the workflow. Criminal databases such as CODIS in the US, the Interpol database, and most European, North American, Australian, and many Asian countries are used for DNA searches of profiles obtained from crime scene samples. Such searches look for matching DNA profiles that could identify the human source of the crime scene sample and connect the crime with other earlier crimes committed by the same person. This accelerates investigations and prevents wrongful convictions. Because of the sensitive nature and high cost of DNA databasing, most nations require a law for its establishment. For more than 20 years, the Philippines has tried to pass a DNA law but has yet to succeed. As of now, 4 DNA bills are being considered, but critical discussions need to address the significant concerns that have been raised. Human rights advocates are worried of potential abuse of the management, security, and access to the sample biobank and database of DNA profiles. In the 2018 UNICEF Security Index, the Philippines showed the highest level of concern over security issues in terms of the databasing of DNA profiles of offenders and suspects involved in heinous crimes, as well as in the biobanking of actual biological and/or DNA samples. Notably, the Philippines has a Republic Act requiring all research involving human participants to be reviewed by an accredited Research Ethics Review Committee. Notably, in one of the proposed bills, an exemption for ethics review of any research for forensic DNA work was included. If passed, Philippine law enforcement agencies can collect samples not only from convicted offenders, but also from any person in the Philippines without any requirement for protocol review. In addition to sample collection from non-convicted but arrested persons, the bills also propose to collect samples from government personnel, street children, and beggars, raising substantial privacy concerns about how the samples and genetic information would be handled. For one, DNA samples can be planted as evidence in any scene, and thus expose the human source, and we mean any government personnel, uniformed personnel, and street children to wrongful arrest and trial. Moreover, the establishment of a DNA database must be carefully considered. In a chapter we published years ago, included in the book Global Governance of Forensic DNA Profiling and Databasing, published by Cambridge Press, we raised the issue of the high cost of genetic testing. To date, one DNA profile costs about 148,577 Nepalese rupees, or about $1,100. Instead of DNA profiling children begging in the streets, can we allocate the funds to social services and education programs for these children? The ethical concerns raised on collecting samples from suspects undergoing trial for inclusion in the criminal database, with none of the proposed bills containing any stipulation for expungement if the person is acquitted. This is of particular concern in the Philippines because the Supreme Court cited the high rate of 76.7% of wrongful conviction of death penalty cases in 2004. Also, without a law, what force or how much force can law enforcement exert to require a suspect to provide a biological sample for genetic profiling? In addition, the advancement of DNA forensics has now allowed law enforcement to conduct familial searches and genealogical testing by collecting the information from persons whose DNA profiles did not completely match the DNA evidence, but were close enough. Investigators will then use these near matches and investigate the family or close relatives to get a forensic investigative lead on another possible suspect. On the misuse of data, these leads would be followed through, and some family or relatives of near matches may undergo surveillance. In addition, DNA technology has also allowed us to generate data on a person's biogeographical ancestry. If not properly governed in a country, such information can lead to discrimination based on ethnicity. Mistakes in DNA matching or mishandling of evidence can wrongly implicate innocent people. Strict legal frameworks and ethical oversight are essential to mitigate these risks. In a project funded by the European Union, we looked for volunteers amongst the prisoners of the National Penitentiary from 2002 to 2005, when the Philippines did not have an ethics law. Now my team recognizes the value of having the protocol reviewed before we implemented that project because of the risks faced by the volunteers in the project. The final ethical concern is that of bias and equity. Misrepresentation or underrepresentation of certain populations in databases may lead to biased investigation outcomes. Firstly, it is important to differentiate between a criminal database and a population reference database. In a forensic investigation, the crime scene DNA profile is first evaluated against a suspect DNA profile. If there is no match, the crime scene DNA is used to search a criminal database. A criminal database containing the DNA profiles of convicted offenders is used to 1. Match the DNA profiles of a crime scene to the offender to identify the offender, and 2. Match the DNA profiles of a crime scene to another crime scene to link crimes. Therefore, the function of criminal databases is mainly for identification. In contrast, a population reference database contains DNA profiles of the relevant population. If the DNA from the evidence matches that of the suspect, there is a need to estimate how common or rare this DNA profile is in the relevant population. This purpose is to evaluate the weight of the profile, e.g., was the match a real match or a chance match? This is what we use the Philippine Population Reference Database for. This database contains the DNA profiles of volunteers from mainstream Filipino populations and those from Philippine indigenous peoples. The Philippines is culturally diverse. Approximately 6% of its population is indigenous, distributed in more than 110 ethno-linguistic groups, with a continually evolving composition and identity, but whose cultural traditions have been passed down through many generations. Nonetheless, many of the communities reside in geographically isolated locations and remain underrepresented in many genomic studies. This underrepresentation impacts the results of health research, limits the utility of databases for forensic applications, and does not allow us to fully appreciate our identity as a nation. Like other Asian countries, the Philippines implements a strict protocol when conducting research involving indigenous peoples. This slide summarizes part of the project implementation workflow, which involves the National Commission on Indigenous Peoples, or NCIP, and includes the requirement for community consultations, agreement preparation, and signing before sample collection. This is what we heard in some of the talks yesterday on social science research, which highlighted the value of engaging communities in dialogue to communicate the nature, value, benefits, and risks of the research. Hence, in the effort to include the underrepresented communities in the Philippine Population Reference Database, adopting an inclusive approach for all willing Philippine populations, a research team traveled to communities including those in highly geographically isolated regions in the mountains and across the river. To explain the project, we used different teaching materials and prolonged and repeated dialogues with the community. During this consultation, we sought the assistance of leaders and members of the community who could translate for us. Only after these consultations, which took time and several return trips to field sites, most of the communities agreed to participate, and volunteers provided saliva samples for genotyping, signing consent forms that had been reviewed and approved by the UP Manila Research Ethics Board. After sample collection, we took the samples to the laboratory for genetic analysis. Late last year up to March this year, we returned to some of the communities to already report and validate the results before we submit these for publication. Community validation, as required by local policies, requires the research team to present the results and seek the response from the community. Are the genetic results consistent with their oral history, cultural beliefs, and traditions? We also sought the community's permission to publish the scientific results derived from their DNA, recognizing the custodial nature of a researcher and that the DNA and all that comes from its analysis remains to be owned by the human source of the sample and by his or her indigenous community. These photos document the validation trips in different parts of the Philippine archipelago that we conducted. Personally, as a researcher, I felt the happiness of the communities who welcomed us openly, recognizing the effort we made to fulfill the promise that we made when we collected the samples. Many were eager to hear the DNA results and share the history of their community that had been passed orally across generations, further strengthening the genetic testing results. The work was not easy and we faced many ethical challenges. I encourage those interested to check two of our papers that discuss the challenges in more depth. We also presented a review of the ethical governance of forensic DNA databases in Southeast Asia, which has a researcher as the foundation because he or she cited all the questions, with 4 stakeholders, namely the research home institution, funding agencies, research ethics committees, and scientific journals protecting the human participants from harm. To end, we recommend the following. Criminal databases in the Philippines should not include suspects. A DNA law must stipulate how samples are collected, handled, accessed, and used. Sample collection must be strategized so that a cost-effective approach can be adopted to define which crimes must be prioritized. Do not include children and street beggars in the database. Instead, the funds should be allocated to specific activities that could take the children off the street and make them productive members of society. Encourage stakeholder collaboration to maximize limited resources. Universities can work with law enforcement agencies by conducting ethical research, passing on validated protocols, and training their analysts. Given the vulnerability of indigenous peoples, we strongly recommend that the reference population database that characterizes genomic variation across Philippine populations be university-based and never housed in law enforcement. Different agencies like the Data Privacy Commission, the National Commission on Indigenous Peoples, the Department of Health, and the Department of Science and Technology should work together in providing safeguards to the handling and archiving of genetic information and biobanking samples to protect all human participants. Thank you and have a good day.
Thank you very much. I forgot to introduce my second presentation. Besides, she's the head of DNA Analysis Laboratory, Natural Science Research Institution, University of the Philippines. She is also the outstanding woman researcher in the life science, organized by the Third World Organization of Women Scientists in Kuala Lumpur. Okay, thank you.
Okay, I now would like to call upon the third speaker. So our third speaker is Mr. Hari Prasad Katel, and he has a MSc degree and he's a PhD scholar. He works in the Central Department of Microbiology, and he's a consultant microbiologist and the in charge of the microbiology department at the TU Teaching Hospital in Nepal. So, Mr. Hari, you have 12 minutes, and please, you may now proceed to.
Thank you. Good morning, everybody. Respected chairperson and co-chairperson. I am Hari Prasad Katel. I am Hari Prasad Katel. I am doing my PhD under the under the supervisor, Associate Professor Dr. Meghraj Banjara and Professor Dr. Prakash Ghimire from Nepal and Professor Dr. S.L.K. Anderson from Norway. This is my part of PhD work, a little bit technical type of study. So topic of genotyping, genotypic characterization of hepatitis C virus from the patient after tertiary care hospital in Kathmandu. You have to change. No change? Next, hepatitis C is one of the hepatitis virus that causes the inflammation of the liver. That can cause the both acute and chronic hepatitis. Majority of the infected patients goes to chronic infection up to 85%. Majority of the infected patients doesn't show any sign and symptom. They are mostly asymptomatic. And 15 to 30% of the chronically infected patients goes to liver cirrhosis and hepatocellular carcinoma later in life within 20 years. Like the HIV, hepatitis B, hepatitis C virus also the blood-borne virus. So transmission occurs through the exposure to the infected blood. So IV drug use is the most common route of transmission. चेन्ज इसको कहाँ देखाउने यो कहाँ कहाँ हो देखाउने यसको यसमा थिचेँ कि मैले According to WHO reports, 50 million people around the world are chronically infected. In 2022, 242,000 people died from the complication of hepatitis C, such as liver cirrhosis and hepatocellular carcinoma. In Nepal, approximately 120,000 people are chronically infected. There are the 7 major genotypes of hepatitis C. Globally, genotype 1 is more prevalent genotypes. Distribution of genotypes and subtypes varies by region, varies by countries. So in Nepal, there is a few genotypic studies so far. There is no vaccine developed yet, but antiviral drugs are available to treat the patients. There is a more than 95% success rate that antiviral drug target the different region of the virus genomes. But mutation on the viral genome may cause the resistance to the antiviral drugs. This type of studies are not done so far in Nepal. So the aim of the study was to identify the SCP genotypes and antiviral drug target gene mutation in the SCP genomes. Hospital-based cross-sectional study was a type of study. Two Teaching Hospital, Marjan Kathmandu, Central Department of Microbiology, and Norwegian Institute of Public Health, Norway were the study site. Clinically suspected hepatitis patients were the target population. Sampling method was purposive. Sample size was 103 patients with the SCB antibody positive. Duration of the study was 5 years, starting from the December 2019 to February 2024. Patients having the SCB antibody positive were included in the study, and patients having the major psychiatric problem refused to participate in the study and undergoing treatment were excluded from the study. Laboratory investigation and semi-structured questionnaire were used as tools and techniques for data collection. Each patient blood were collected and tested for anti-SCP positive by ELISA method. If found positive, also you did the ELISA for HIV and hepatitis B as a co-infection. Among the antibody positive SCP, we did the PCR to know the status of RNA, SCP RNA in the blood. If among the RNA positive, we did the whole genome sequencing to detect the genotypes and to identify the drug target gene mutation. before start of conduct of this research, we applied the proposal to Nepal Health Research Council and got approval from the NHRC Nepal. We also got the approval from Tribhuvan University Teaching Hospital. As some of the parts of the tests were done in Norway, so we got the approval from Ethical Committee of Norway. So before transporting the SCB RNA to the Norway, we made the material transfer agreement between the Norwegian Institute of Public Health and Central Department of Microbiology. And before taking the samples to the Norway, we also informed the NHRC. And I explained individually the patient who is antibody positive, counseling him about what are the disease conditions, and we assured his confidentiality and also assured this is hepatitis C nowadays is curable disease, more than 95% curate, and we also educated him how to prevent the transmission to the family and other member, and we try to alleviate their fearness because it is the hepatitis C, the curable disease, and they can spend the healthy life like us after the cure of disease. Out of the 77 districts of Nepal, patients were from the 49 districts of the Nepal, so mostly from the Kathmandu Valley. Sex-wise, higher prevalence was found among the male population. Caste-wise, higher prevalence was found among the Janjati population. Age-wise, higher prevalence was found among the young age group between 15 to 47 years. As Hindu are predominant population in Nepal, so 77.3% patients were Hindu. And one of the risk factors to develop the cirrhosis earlier is alcohol consumption. So 33.2% patients were regular alcoholic. To prevent the transmission of disease, education is very important. Still, the 8.5% patients were illiterate. Among the literate population, up to the secondary level education, mostly patients were having. Other risk factor is a co-infection, HIV co-infection and hepatitis B co-infections that are the risk factor to develop the cirrhosis earlier. So 6.6% patients were also co-infected with the HIV and 1.4% patients were co-infected with the hepatitis B. We tested the antibody positive blood sample by PCR method. We found 70.6% of the patients having the SCB RNA in their blood, and 29.4% were having no RNA detected in the blood. It means that 29.4% patients will recover naturally. They do not need further treatment. That is very important. Only approximately 70% patients go to chronic infection. Chronically infected patients only needs the treatment. Who are the naturally cured, they do not need the treatment. But they have antibody positive. When tested the RNA, they were found RNA negative, SCB. Talking to mode of transmission, most predominant mode of transmission of IV drug use, 45.5%, followed by sexual route of transmission, 28%, blood transmission, 6.2%, hemodialysis 4.3% and other. Still 11.4% are unknown. Sorry. We did the whole genome sequencing of the 44 SCB genome in Norwegian Institute of Public Health by the Illumina MySeq platform. We found that 68.2% of the SCB was genotype 3, subtype A, followed by 18.2%, 1A, and other subtypes were each one. Among the IV drug use route of transmission, majority 71.4% were infected with the genotype 3 subtype A, followed by genotype 1A and 1B. Among the sexual route of transmission, majority 70% were infected with the genotype 3A subtype A, followed by 1A 20% and 3E 10%. Very difficult. It's very difficult to change the slide. So antiviral drugs are available to target the different region of the SCP genome. So 70.5% were resistance found in the non-structural site of 3,4A, and 20.7% of the SCP found resistance on non-structural site 5A, and 45.5% of the SCP genome found resistance to NH5B, polymorphin mutation, resistant mutation detected. For the all genotype, these are the list of the antiviral drugs that are used for treatment of the hepatitis C. So only we could not detect any resistance to the only latipasvir. In most commonly used antiviral drugs are the sofosbuvir combined with the other antiviral drugs. Clinician prescribe the drugs empirically, combination of the drug covering the all genotypes. But we could detect the resistance in some extent except latipasvir. For genotype 3A, only sofosbuvir, dasabuvir, latipasvir, and voxilavir we could not detect any resistance. And remaining all antiviral drugs, we could detect some extent of resistance. Compared to genotype 3A, less resistance was detected in genotype 1 and subtype A. Only the grazoprevir, piritaprevir, and voxilavir resistance were detected. In conclusion, predominant SCP genotypes was 3 and subtype A are circulating in our regions, and resistant mutation in antiviral drug target genes were detected in the SCP genome, and SCP genotype subtype 3G, 3I identified first time from Nepal. These are my acknowledgement. Thank you.
Thank you. So we move for the next speaker. This is the title of Ethic Review of Bioequivalence Studies by Dr. Lida Sitoras, right? She's a senior researcher, professor, consultant at University of Indonesia. By training, she is an ophthalmologist, and then she now is in the Forum for Indonesia Recognized Research Ethics Committee, Supervisory Board, MTA Committee, and Badan Kebijakan Pemhang, I don't know, I cannot pronounce it, is from Ministry of Health. Sorry about that. Okay, welcome, please.
Thank you, moderator. Good afternoon, all. I would like to present some topics that is maybe a bit unique, but very important for our Health Research Ethics Committee, because this protocol submitted to our Research Ethics Committee quite a lot, the bioequivalence study. Oh, it's not. So finding generic equivalent of brand name drugs has always been the strategy for reducing the cost of the medicine. For that reason, the BE or bioequivalent and bioavailability study aim to obtain approval of genetic equivalent of the branded name drug is recommended. And so far, there is an increasing number of BA protocols submitted to ethics committee. But one important thing is that human subject for BABE studies recruited by the CRO, Clinical Research Organization, might be very potentially vulnerable. For that reason, several ethics concerns needs to be considered. So this is a bit overview about what is bioequivalent. The two medicinal products containing the same active substance are considered bioequivalent if there are pharmaceutically equivalent or pharmaceutical alternative, and their bioavailability rate and extent after administration in the same molar dose lie within acceptable predefined limits. Usually, these two formulations are compared in a study, randomized, 2-period, 2-sequence single dose with crossover design. And in between, there are sufficient washout period. The unique of the BE study compared to other non-BE study is that healthy volunteer subjects is required. This is important to reduce variability not related to formulations, differences between products. Usually there are requirements for the human healthy volunteer subjects. Adult subjects, 80 to 53 years of years, and screened, they have to undergo the screening by clinical laboratory tests, medical history, and physical examination. Usually no gender distinction, although the woman of childbearing potential should be not allowed. Preferably non-smokers, non-history of alcohol or drug abuse. In the study, they have to undergo repeated blood sampling, about 16 to 18 times per sequence, and the study consisted of 2 sequences. So quite a lot of blood sampling, and understand under fasting condition within the 24 hours. The healthy subject receive compensation for their participation in the study. The question is what amounts. That should not be too much because it could be as an inducement, but not too little because it will compromising the welfare of the subject. The common formula that is in our standard is based on the number of visits or time, estimated time loss, traveling cost, and inconvenience caused to the volunteers due to the number of blood sampling. State whether the participant will be eligible for compensation when they withdraw for the study before the study ended. I would like to share sad stories reported by Pula, lured by blood money. You can read it, search it in Google. Say that Mr. X, 33 years old, resident of somewhere in the world, participated in over 25 clinical trials between 205 to 9. So the question arises, how is the eligibility? And 1 year after this, he began experiencing severe seizures and other mental system. And he went to the doctor, government doctor, who told him that his health complaint could be due to the repeated participation in clinical trial. On the left side, on the right side, you can see how the daily activity of the family. Next to him is his mother, and perhaps is coming from the not a vulnerable family. So there are financial pressure to be included to participate in the study. The risk of exploitation is the challenges in the BE study. The question is how to protect the healthy volunteers from any potential risk of harm or exploitation. Our ethics committee is an old ethics committee in Indonesia. FKUI Cipto Mangunkusumo Hospital Jakarta aims to conduct a study with objective to evaluate current practice and regulation concerning information that has been given to research subject when obtaining consent in BE study. And we specifically focus on to analyze elements in the informed consent form that was developed by CROs. This is the material and method. All BE study retrospectively reviewed during the year 2033 were collected and analyzed. And then two informed consent at that time period developed by each of the CRO were randomly selected and then analyzed the following items of the informed consent based on template developed by the enhanced ICF formula by Sitzer. The elements is the scientific soundness of the study, right of the study, volunteers requirement, confidentiality, monetary compensation, etc. And then after that, we interview the representative of CRO specific subject about the specific subject's eligibility criteria. The result is on the right panel. We found 302 BE reviewed protocol from 7 different CROs. We collect and analyze and randomly selected. And then we found 14 ICF representing 7 CRO, selected and then analyzed according to the informed consent forms developed by Sitzer. And then after that, we interview 7 CRO on about the specific subject selection criteria. And this is the result. We found 302 protocols in 1 year and derived from 7, submitted from 7 CROs. And then, yeah, this is the recommendation. And the reason for recommending protocol revision of BE study submitted is like in a monitor. Most of the revision recommending for resubmission or for revision is on the informed consent, about 68%. The reason for that is because the informed consent do not meet the standard developed by our ethics committee on the compensation of the subject. We analyzed then the element of informed consent. 14 informed consent analyzed and then selected, and then we analyzed. And we use the elements, as you may see on the right monitor, is the item, the elements that has to be in place in an informed consent, which is general items, right of the subject, scientific aspect, and ethical aspect. We found that there are different ICF templates developed by the CRO, but all of them have included those 4 elements. This is just to show you the difference between enhanced informed consent form versus the conventional informed consent form. And the red box, there are the difference. You may learn about it later on. And I would like to emphasize the box subject, the subject eligibility on the enhanced ICF and conventional ICF, that the statement subject must not take part in the similar study during the 3 months from the start of the study, not there in those both informed consent. So, subject eligibility. The statement that subject must not take part on a similar study during the 3 months from the start of the study should be there in the informed consent. And from the ICF that we analyze, in our study, all of the ICF developed by CRO already contain this statement. So the question is, can the ICF statement alone be relied on to anticipate the over-volunteering, multiple repeated participation of the subject? It is rely on? No, because ICF should not be based on only checklist data alone. It is a process. So why financial pressure makes subject dishonest in eligibility criteria? They can check, yes, yes, yes. Yeah? And then the question is how to verify it, how to ascertain. So there are verified centralized database system, healthy volunteers registry in Malaysia, for instance, and online volunteer systems should be there to confirm, to ascertain the eligibility of the subjects. Okay. This is the online database register in our country. All the CRO have centralized subject database system between the BE centers. This is based on the national ID card, so would be enabled to track the subject latest subject participation if he is eligible or not. So on the right, this is the guideline from our ministry, Indonesian Ministry of Health, that each BA study center must have centralized subject database between BE centers, which is managed by an independent party while maintaining subject confidentiality. That is the regulation from our government. So this is just the example of the database. So as the take-home message, healthy volunteers are vulnerable group in BE study. They should be protected to reduce any potential risk of harm or exploitation. The health authorities and ethics committee should continue monitoring. It is critical. The challenge is, overworked ethics committee may wrongly assume that routine BE studies require less scrutiny than rather first-in-man studies. The other point is, in the ECF, informed consent for BE study needs to contain specific item for subject eligibility. The statement is, must not take part in a similar study during the period 3 months from the start of the BE study. The centralized database system, centralized health volunteers registry is important in the recruitment process of the prospective subject. Our study showed completed elements of ICF, but this is not the end of the goal. It still should be ascertained through other means. For instance, the online volunteers database system. I think that is the end of our study.
Thank
and
you.
we thank also as Widyahaning, who participated, and also we conducted the same this study with her. Thank you very much for your attention.
Okay, thank you very much. It's very interesting topic. If you have any questions, you can entertain, the question later after the session. Thank you.
Thank you, Dr. Rita, for your presentation. Now I would like to call upon Dr. Swetcha Vaidya for her topic presentation on neonatal sepsis and developmental outcomes. Dr. Swetcha is a medical doctor as well as a young medical doctor and holding a medical degree, and she also has a postgraduate degree in public health. She is currently a PhD scholar at the Amrita Institute of Medical Sciences and Research Center and a lecturer at the Patan Academy of Health Sciences. She specializes in neonatal care practices, infection control, and long-term neurodevelopmental outcomes. So we will be listening to her experience on the cohort study, and in addition to her clinical and research work, She's an experienced educator dedicated to mentoring future healthcare professionals. Thank you, Dr. Swecha. Please, you may now start.
Good afternoon, everyone. My name is Sweksha Vaidya. So topic of presentation today is neonatal sepsis cases and their developmental outcomes after 6 months in Nepal. So this actually is an underlining subtitle we have. We are seeing the impact of neonatal sepsis on neurodevelopment of a child. So background of the study, as we know that by definition, neonatal sepsis is actually a systemic condition which is in bacterial, viral or fungal infection in newborns. So neonatal period is about from 0 to 28 days. And so we have given some global relevance to it. So it actually affects the neonatal mortality rate. So in approximately 2022, approximately 2.3 million neonatal deaths occurred globally, but in South Asia, it was 34%. So in WHO estimates, we see that the annual cases of neonatal sepsis estimate from 1.3 to 3.9 million, in which the leading cause of death occurs in 400,000 to 700,000 neonatal deaths each year, highlighting the significant impact on infant health. Now, talking about the burden, in case of Nepal, we have seen a hospital-based study. So hospital-based study, we see that there is a ranging of prevalence of neonatal sepsis from 2% to 4%, and 37% of those neonatal sepsis cases were come from the NICUs. So impact on neurodevelopment. So what is neurodevelopment? In case of neurodevelopment, we have taken DSM-5 module for the definition. We say the development is delayed if it is less than less than in one or more domains. So one or more domains, what are the domains? We can see motor, cognitive domain, socio-emotional. These are the domains of the development. So in central nervous system, we can say that the development starts from our embryonic life up to the early age. So any insult in this part of this part will have an impact on the neurodevelopment of the child. So study rationale, we have already talked about in the previous slides, high prevalence of neonatal sepsis, impact on developmental outcomes, informing the health practitioners. So this comes after the study has been completed, and then we can inform whether the impact has been that massive that we can change any kind of hospital protocols, standardized protocols or policy at the end. So need for longitudinal study, and global relevance was already discussed earlier. So need for longitudinal study. So in this case, this is the first study that actually is in Nepal that we have seen that associates the neonatal sepsis with the neurodevelopmental outcome. So we have not done any other study. We have neurodevelopmental studies, but not with the neonatal sepsis. So objective of our study is to see the prevalence of neurodevelopmental delay in neonates who have been documented sepsis. So in following in a 6-month period, and the predictors, secondary objective may be the predictors of neurodevelopment delay in neonates with documented sepsis, and associations between neurodevelopment delay in neonates with documented sepsis, demographic, socioeconomic and clinical variables. So in case of study design, we have done a prospective dual-centric cohort study design. So number of patients recruited, so this is an intermittent finding. The study is still ongoing. So number of patients recruited is 395. So we have done around 241 6 months follow-up. And the sample size actually we have taken from a pilot study. It was 185, but we are planning to do more sample size for the robustness of the study. And the study sites are 2 study sites in Nepal. One is the Paropkar Maternity and Women's Hospital in Kathmandu, and second one is the Siddhi Memorial Hospital in Bhaktapur. So in case of selection criteria, we are including all the neonates who have the documented sepsis attending to hospitals we have said earlier. So in this, we have excluded severe life-threatening conditions, gross genetic or congenital malformations, neonatal or post-neonatal death before 6 months follow-up, and perinatal asphyxia, HI grade 2 and 3, because this itself will cause neurodevelopmental delay, and birth weight less than 800 grams, and extreme preterm less than 28 weeks of gestation. So study timeline, actually this proposal was submitted in November 2022. We had scientific review board approval of Amrita Institute of Medical Research Science, where I am doing the PhD. And we had the scientific review board approval from Prasuti Griha, then we have the scientific approval from Siddhi, and then we get the approval from NHRC on January 2023. So after that, the enrollment started at February 2023, and in October 2024, recently, we have stopped it's still going on. The enrollment is around 395 and follow-up is around 241, which was said earlier. So data collection tool. So this tool actually was designed for Indian infants, but this is adaptation from the Bailey scale of infant development. So this is a culturally appropriate tool for South Asian countries. So this tool actually has there are two parts of this tool. One is the performer that we are doing in neonatal sepsis. When we find out the baby has the neonatal sepsis, we take the baseline parameters from the performer. And at 6 months, we are doing this tool that is development assessment tool for Indian infants. So origin and foundation of the tool is, so this tool was developed from Dr. Pramila Pathak, MS University of Baroda. Actually, this tool was derived from Baroda norms and Bailey scale of infant development. So domains and clusters of the tool are two domains we have doing majorly. One is the mental domain, another one is the motor domain. And in mental domain, we have 10 clusters, and in motor domain, we have 5 clusters. So in 5 clusters, we have like a body control, neck control, and in mental domain, we have cognitions, all those things. So age-based item placement. So it is a percentile rank is there. So age-based item placement is done by 50th percentile, 3rd percentile, and 97th percentile. So in this study, we are taking the 50th percentile. And another thing is that the items are given according to the domains. So motor and mental domain, motor domain, we have 163 items, whereas the mental domain, we have 67 items. So this is how the assessment kit looks like, and this is how we do the assessment. During the assessment, we need a soundproof room. We have to do the assessment. We have the particular sizing of the furnitures and all the assessment kit should be there, and the baby's placement and all the motor and mental parameters should be there. And we have an item checklist where we do the assessment, and it takes around 30 minutes to 1 hour for a child. So outcome variables, as we talked about earlier, the 2 domains, and the cutoff point we can talk about is in this scoring we do the scoring for these babies. So in the scoring 70 and below, we say the baby is delay. So and above 70, we say it's not delay. And in 70 and below also, they are divided into mild, moderate, and severe delay. Whereas the mild delay is 70 to 50, moderate is 50 to 30, and severe delay is less than 30. So secondary outcomes, so we talked about the clusters earlier. So in those clusters, we have the cluster performance percentile ranks. So what we do is we categorize those clusters as well, like motor and mental domain are categorized into clusters. And these clusters are categorized into delay or not delay, average, below average. So actually the 10th percentile is the delay, less than 10th percentile is delay, more than 10th percentile we can say it's no delay. And we have already talked about the mental developmental clusters and motor developmental clusters earlier. So actually it is an intermittent finding. The study is still going on, so we have just kept the major findings here. So this is a cohort profile actually. The socio-demographic variables in this, we see the male are more in frequency in 54.4%, and the family type that they are in are 57.7% the cohort is in. So maternal education, so we have secondary or below. This is actually in Nepali we say SLC or below, or 10th or below is maximum, that is 43.5%, and maternal age 25 to 35 years 55.5%. So maximum are those in cohort. So socio-demographic profile, this we have used the modified Kupuswamy scale, which is adapted towards Nepal only. So in this what we did is we saw that 48.22% was in the upper lower class. And then what we found an association between socioeconomic class and neurodevelopmental delay with the babies of the neonatal sepsis. So there is a motor component and mental component. We have divided into 2. So among the 11.6% of the individuals from the upper middle class, we found that 20.7% was observed to have the motor delay. And among the mental delays, we have 48.2% of the upper lower class, that was the maximum in our cohort, had 23.4% of the mental delay. So clinical variables of the cohort profile. So we had divided the gestational age by term, preterm, birth weight by normal birth weight, low birth weight, and assisted ventilation, then neonatal sepsis and mode of delivery. We had majorly term babies, that is 63%, normal birth weight babies 55%, and assisted ventilation in 54.2%. So what we did is we have taken both the neonatal sepsis, documented neonatal sepsis, meaning culture positive, as well as the culture negative sepsis. So culture positive, whatever we get the report, we have the report that that they are culture positive. But culture negative sepsis, we have the criteria for it. We have given 5 criteria. One is that antibiotics should be given 5 or more days. Second one is that the clinical features should be 2 or more. And third one is abnormal WBC count, CRP level or PCT level. Fourth is the culture negative, it should not be culture positive, so obviously culture negative. And the fifth one was that no other concurrent focal infections such as pneumonia, UTI should be there. Then we say that the babies have the culture negative neonatal sepsis. So, so there is severe, moderate, and mild delay, overall delay developmental quotient. So what we saw is in the 21% of the motor delay, we found out that the cohort had 21% of motor delay and 17% of the mental delay, and they are categorized into severe, motor, and mental delay. So sex association with the neurodevelopmental impairment, we saw that the male sex had more neurodevelopmental delay when compared to the female ones, which is also backed up by the previous literatures. So these are the 3 predictors that we found out that caused the neurodevelopmental delay along with the documented neonatal sepsis cohort. So gestational age had odds of 1.56 higher odds of having the neurodevelopmental delay if the gestational age is lower in the motor component, and in the mental component it was 1.43 times higher odds of having the neurodevelopmental delay. In the meconium stained LICA, that is the amniotic fluid stained with meconium, it is 2.35 times higher risk, and culture positive sepsis had 2.14 times higher risk of it. So in discussion part, we have taken three studies. So accordingly, from our study, we can say that the delay was from 17 to 21% in both preterm and term infants, and with the three key predictors. And it's same like that study. We had 2018 study, which was slightly different. It was taken from USA. They had taken the military records from it, and they had a 5-year follow-up. So it was a retrospective study, but they had the cases from 28 to 50%, but there were some cohort differences. Similar to our study, one Eastern India study was similar because 18.18% rate of developmental delay was found at 1 year of follow-up. And another similar study was 2011 Swiss cohort study, which showed that the increased risk of neurodevelopment delay, increased odds of risk of neurodevelopment delay was 1.85. So in conclusion, so actually the ethical issues that we've addressed in this prospective cohort study, actually it is an observational study. So we didn't have that much of ethical issues, but what we did was we gave the informed consent, and then we had the privacy, all the general things we had done it. But some way we had been caught up with the situations in the data analysis, data collection part, when the mother has given the consent, but the father denies at the end in the enrollment part. That was a little challenging. And in follow-up, so what happened is the enrollment they had done during the follow-up, because it is a longitudinal study, we have loss of follow-up. So loss of follow-up was one limitation, and also during the follow-up when we call them, and if the mother-in-law or father, the daughter-in-law have some conflicts, so they start actually blaming us for those conflicts when we call them. So I think there is some, okay. Thank you so much for today.
Very interesting. We need a little bit more time, you know. Anyway, we go to the next presentation. It's the last one, and then after that we can get a lot of entertainment by question and answer. The presentation about the application of research ethics in Ayurveda research by Dr. Laxman and Dr. Veena Vasami. He's a research ethics scholar from India, right? And then he now as a professor, Department of Medicine and Toxicology, Director, Center for Ethics, Paya University, and in the Mangalore program, right? Welcome, please.
Hi all, so I am myself Skandesh Lakshmanan, and my guide is Dr. Veena Vaswani. So I represent Center for Ethics, Yanapur University Foghat International Center, Mangalore, India. So I welcome all of you to the study. So this is the study one of the kind of a study which directly tried to explore a research ethics aspect of a health research. So exploring the research evidence and the application of the research ethics concepts in Ayurveda research. It's a qualitative study based on the analyzing the perception of the researchers. So this is my short bio profile. It's already being presented. So I acknowledge the support of USNH because the study has been done as part of an MSc Research Ethics program, which is supported by USNH. So I acknowledge their support in this program, and we declare no conflict of interest with this presentation. And the same presentation based on this study has been done in one of the National Research Ethics Forum in India, which was taken part in the last month. So introduction. So coming into the evidence-based medicine or EBM, we know that EBM has revolutionized the clinical practice by shifting the focus into informing clinical practice from systematically conducted research evidence rather than just based on the expertise opinion. So we know that the evidence-based medicine also has a critical component called hierarchical evidence model, which is classify the causal effect, causality based on the ranking. So we know that the pyramid contains the lower end and upper end as case reports to the systematic review and meta-analysis. So the hierarchical evidence model also considered to find many limitations when it comes to assessing the complex system. So complex system means the multiple interventions and the multiple therapeutics involved system. So like we say that surgery, psychology, rehabilitation, traditional medicine per se, nursing care. So this system is already observed to have a limitation when there is an assessment with the hierarchical evidence model based evidence-based approach. So there are already observed scholarly observation based on that. So when it's come to the context of traditional medicine, so the traditional medicine, especially in Ayurveda, which the current context of the study, Ayurveda is an Indian systems of medicine, which has thousands of years of active practice in India and subcontinent. And also it produces many anecdotal evidences and available scientific evidences also. But one of the major limitations in integrating Ayurveda into the mainstream healthcare or globalized healthcare is it's perceived to be lack of high quality evidences. So one of the argument for the lack of high quality evidence is also based on the fact that the Ayurveda research is also lacks the appropriate research designs which actually need to be explored from the perspective of the scholars. So another part what is important here is that the researchers working on the particular knowledge domain is also observed to have their perception also to be influenced by their selection of the particular research methodology. So the researchers' perception based on what they constitute or what they perceiving as their base of their knowledge structure, their base of their epistemology is also important in selection of their research methodology. So here we thought to explore what is the perception of the Ayurvedic researchers or the researchers working in Ayurveda, how they perceive it as their suitable evidence-based approach for applying in their own research, and also what they perceive as the applicability of the research evidences to be applied in their domain of the research. So the objectives are the research evidence approaches perceived by the researchers working in Ayurveda, also the applicability of research ethics principles in Ayurvedic research perceived by the researchers from southern part of India. We can see the mapping here. So our participants are from this locality. So the methodology, it's a qualitative study, and the study is done in online platform, and it's exploratory study. The study was based on the in-depth interview, and we have done thematic analysis as part of the analysis, and the inclusion criteria, as we can see the Ayurvedic researchers who have a specific expertise and experience like 3 years, and exclusion criteria was that the researchers who lack the experience in human participant research, and it got an approval from our institutional ethics committee. So the results, so there were 3 female participants and 4 male participants. We can see the demographics. So we have a participant who has a sufficient experience in the Ayurvedic domain as well as the research field. So we can see most of them are coming from PhD background and postgraduate background, and 1 participant are coming from an emergency medicine background. So we try to have a diversified participant as possible, and many of them has PhD also. So we can see that the three core themes what we have generated from the study consisted that what counts as evidence in Ayurveda research and evidence through whose lens and research ethics application in Ayurveda research. So these are the major core themes which helped us to arrive at the critical synthesis of the study, and the secondary themes which has helped us to generate these core themes, like you can go through the evidence-based medicine perception, application of Ayurvedic evidence approaches, and status of Ayurveda research, etc. So what is important is that the majority of the participants, which we have conduct these studies, like 7 participants in depth interview, so they perceived that the major characteristics of Ayurveda practice as based on the personalized approach, holistic practice, and the real world practice. So there were a strong demand that they felt that these characteristics need to be accommodated in the research designs and research evidence approaches. And the participant who had worked in a very unique research designs had more clarity when it comes to designing appropriate research model for Ayurveda research. Also, they had more clarity when research ethics need to be applied in Ayurveda research. So what is another important thing when it comes to the analysis is that their perception of the hierarchical evidence model, especially in the randomized controlled trial. So the usage of randomized control trial perceived by the Ayurveda researchers, not just because of the scientific merit, but because to get some legitimacy from the major scientific domain. So they feel that if they are other with the randomized control or hierarchical evidence model, their domain may get more legitimacy from the biomedicine perspective. So we see that this approach and attitude of aligning with the hierarchical evidence model or RCT with the Ayurvedic research, or also resemblance from the Bourdieu's theory of symbolic power. So this Bourdieu's theory of symbolic power gives us an understanding that we perceive certain kind of power hierarchy, but we unconsciously perceive it. And because that we feel that it is a normal thing, social normality, so that we don't feel it as an imposition, but it is like imposing in our daily life. So that Bourdieu's theory is giving us like how unconsciously this power, kind of an monopoly is playing on our daily life and social structure. So here we can see the structure of hierarchical preference evidence model, which is perceived by the Ayurvedic participants apart from the hierarchical evidence clinical approach. So black box design. So the black box design is considered to be very novel research design. Is come in the domain of real world practices. So in the black box design, there is a real world practice. So the whole system can be assessed in this design. So there will be randomized double blind, but a real world clinical assessment of the traditional medicine can be possible in the black box design. So this model is perceived as a suitable model from most of the participants, and we can see the case report coming in observation studies, and RCT is coming as the less preferred model for the traditional medicine in terms of its merit, but they considered it as a very important model to gain a kind of a propagation or a legitimacy, as I mentioned before. So, and we come to the analysis, so we can see that the quotes what we have gained is directly linking that they say that they know that RCT are not golden standard, but it is important to propagate their domain. So that which is actually resemblance from the scholarly observation what we can see that Ayurveda research needs a freedom from RCT considering its whole system approaches. So our quotes and our insight from the participant resemblance with what we are seeing in the existing literature, also many similarities and also some difference are there, but we are just going through it. So we can see that black box design again preferred as a real world practice model. And here, evidence from whose lens? So here we see that the biomedicine is considered to be one of the direct power influence factor in designing and influencing the way how the researchers in Ayurveda perceive their research model. So as I mentioned before, RCT is being considered as a dominant model. Why? Because it's considered to be a hierarchical model in the biomedical setting. So the modern medicine domain is perceived to be a power agency which dominates over the selection of research methodology in Ayurveda. So what is important is that another study which was done on traditional Chinese medicine, acupuncture, also resemblance the same. So but there they actually try to have more active resistance considering it as a more biomedicalized. But here there is much more kind of submersive kind of an acceptance of the hierarchical evidence model as a superior model, but still they feel that it has a limitation. And when it comes to the research ethic application, the Ayurvedic research perceptions all indicates that they actually perceive the research ethics need to be contextualized in their characteristics of practice. So interestingly, the autonomy, what they transcend also that they transcend the idea of autonomy beyond of the research ethics axionomy. So we see that in the research ethics conventional axionomy more related with informed consent form. They also feel that informed consent form is important, but beyond of that, they feel that autonomy also need to be transcended in the freedom of Ayurvedic researchers also to design their own research model which can be suitable. So that is one of the transcending aspect of autonomy they perceive. Also they perceive the research ethics aspect to be also contextualized based on their characteristics of practice, which we can see in the Tibetan medicine research, which is done by Vincas Adams. So in the conclusion, in our study, we feel that the Ayurveda researchers perceive the characteristics of Ayurveda practice like real world practice, personalization, holistic care to be integrated to consider as a research evidence, model approaches. And also what is important is that Ayurveda researchers perceive the hierarchical evidence model not just because of the scientific merit, but as per the Board's theory of symbolism, it's like a monopoly, and they feel that it gives them more legitimacy. And also it is important to see that the research ethics concept, also they feel that it's need to be contextualized in their own settings of knowledge, their own settings of the research paradigm. And limitation that we are not able to have much more diversified participants from all other biomedicine researchers also working in Ayurveda. And these are the reference, and these are my word cloud based on the some of the themes we generated. And I thank for the forum and thank for your audience, and the audience made this presentation. It will make a great. So I thank you.
Thank you. Thank you, Mr. Lakshman, for a very interesting presentation talking about Ayurveda and ethics in Ayurvedic medicine. But I think we are at the end of all the topics now, and we have run a little over time, but we have about 5 to 10 minutes for questions and answers by the researchers, if any. So please, I invite the audience to pose their questions now. If anyone has questions, please come forward with them. Everyone is hungry? No one wants to ask any questions?
Okay, thank you. So my question is to Richan Shrestha. Okay, very good. And also a very general question, as our co-chair has already mentioned that as this is FERCAP conference, it would be really nice to discuss more on the ethical parts rather than discussing your clinical research findings. So there are many presentations where I think could be a lot of ethical challenges. So I would really appreciate our speakers to share their experience on ethical challenges later on. And to Richan Shrestha, my question is, it's a very nice systematic review presentation. So my question is why you have selected only Scopus and Web of Science, though you have mentioned that as a limitation, but when you select your database, it really depends on your field of study. So maybe there are specific databases that interest mainly your research work. So that is one of my queries. And the second one is, when you make such presentation on systematic review, that's just my suggestion that it will be really nice if you just present one slide on the process of, how you selected your studies, basics for selecting your studies, and it will be really nice if you could just present one, Excel sheet on telling us, what were the research questions, what were the eligibility criteria for including your 52 studies. That would have made your presentation really valuable and very clear to the people audience like us. Thank you.
Thank you very much for this wonderful concern. for your second concern, I'll go first with. Actually, there was one slide showing all the process, but because of this problem on the screen, so I could not, because it was my first presentation and I could not show that. It was all gone blur. So actually there was a process, all those process, like including the inclusion criteria, exclusion criteria, which were excluded, so and how that 52 articles were extracted, it was there. Unfortunately, like because of the problem on the screen, so it was not visible. So that was there. And regarding second questions, why I choose Scopus and Web of Science database, I think these two databases are one of the most reliable databases, and because of this reliability and also the trend, like I follow, like I went through the literature, and many previous Prisma model have used these two databases as a reliable source. That's why I used, and I definitely take on that point. As I said in my limitations, we could have gone with the many other databases that could have bring other diversified discourse on my issue. Thank you very much for the concern. I can, by the way, I can share my that slide which shows all the process. Thank you very much.
I have a question for the second presenter, not you. Thank you. That happened with online, so I'm not going to get any answer from that. But I have some comment on that. When you're talking about forensic medicine, genotyping or population genotyping, you have to specify what kind of method you use. I use the whole genome sequencing or target genome sequencing or whatever. If you go for the whole genome sequencing, it's going to be, one is the population genetics. Another issue that's very important for the ethical part is the incidental report from the whole genome sequencing in population genetics research. Because you get some information that's very bad with some disease or something happened. That needs to be in the informed consent, and you have to keep back all the information with the expert. So just a little bit on that, comment on the second presenter.
Yeah, thank you very much, Madam. And I think we can close the session now. And I think I had sort of specified it before, and it would have been very good to listen to more ethical concerns and ethical issues in all the studies, because that would have made it more more interesting, I guess. But there was a lot of science in it, but we would have loved to hear some of the ethics portions, although you tried to bring in some issues. But since it's lunchtime, I don't want to go into the summary, and I think we would like to end and not keep you waiting for your lunch. But thank you so much to all the presenters, and thank you to the audience for your patient listening. Thank you very much.
Okay. Thank you to all the presenters for such an insightful presentation. With this, we are at the end of this session. Now, I would like to invite our presenters to come forward to receive the token of love. And I would now like to request our honored session chair to proceed towards the stage and present the token of appreciation to the presenters. Mr. Richan Shrestha. Mr. Hari Prasad Patel. Dr. Rita Steros. Dr. Soicha Vaidya. Dr. Skantes Lasmanan. I request all the presenters to be on the stage for the group photo. Moving ahead, I would like to invite Professor Dr. Jeevan Bahadur Serchan, former Chair of Ethical Review Board NHRC, to come on the stage and provide the token of appreciation to esteemed chairs of the session. Thank you. Lastly, I apologize for any mistakes or misunderstanding during our session. We appreciate your patience and understanding and look forward to seeing you on upcoming session. After lunch break for 60 minutes, let us meet at this hall at 1:30 p.m. for the upcoming session. Thank you.
afternoon, everyone. It is my pleasure to welcome you all to this engaging session titled Improving REC Performance. In this session, we shall focus on exploring strategies to strengthen research ethics committees, enhance their communication, and address common challenges they face in supporting ethical research practices. I am Prakriti Sharma, speaking on behalf of Nepal Health Research Council, and it is an honor to be your facilitator for this session. To begin with, I would like to warmly welcome our session chair, Dr. Magdalena D. Agitini, to the stage. Dr. Magdalena is a distinguished surveyor at the National Health Research Ethics Commission and the National Institute of Health Research and Development. With a wealth of expertise in ethical review and governance, Dr. Agitini has significantly contributed to advancing ethical standards in health research. Next, I would like to welcome Dr. Pradeep Gyawali on stage. Dr. Gyawali is Vice Chancellor of Madan Bhandari Academy of Health Science and Distinguished Harvard Scholar, having completed the Global Clinical Scholar Research Training Program at Harvard Medical School. He brings extensive expertise in clinical pharmacology and health research, having previously served as the Executive Chief and Member Secretary of Nepal Health Research Council and as the Head of Research Department at Institute of Medicine. During his tenure, Dr. Gyawali initiated several groundbreaking clinical research projects in Nepal, including pivotal COVID-19 studies such as the Recovery Trial and the WHO Solidarity Trial. For his contribution to minimizing disaster through research during the pandemic, he was awarded the prestigious Best Prize by Nepal's Ministry of Science and Technology. I now request our chairs to take over and guide us through the session. Over to you, chairs. Thank you.
Thank you, Prakriti. And I'd like to thank you, first of all, the organizers of the FERCAP 24th Conference Committee to give us the chance to participate as a chair of this prestigious conference of the topic REC performance. So we have different 5 presenters from different specialities with having different expertise. 2 of the presentations, first and the 4th presentation will be online, and the 3 of the rest presentations are in-person or live presentations. We have the presenters, Ashok Kumar Mandal, Nuntip, Dr. Mohanraj Sharma. Likewise, we have the presenter, Norwining and Kevin Martinez. First of all, we would like to welcome Dr. Ashok Kumar Mandal. So he is from the University of Malaysia. He is going to present the topic online. So he is from Kuala Lumpur, Malaysia. Okay, so he is going to present online. Let's start the presentations. Ashok Kumar Mandal.
Hello everyone, Namaste. I am Ashok Kumar Mandal from University Malaya, Malaysia. Today I am honored to be the part of 24th FERCAP International Conference and to present on the topic that aligns closely with the theme of this conference, that is, maximizing benefit through responsible conduct of the research. I will be presenting my research entitled Necessity of Bioethics Training for the Health Researcher and the Volunteer Engaging in Community-Based Research. Looking into the background, research ethics is upheld by 4 main principles: autonomy, beneficence, non-maleficence, and justice. It plays a critical role in guiding researchers beyond compliance with regulation. However, in a competitive and funding-limited research environment, risk of misconduct arises. Presently, we are living in an environment where publish or perish is the motto, and there is a high level of performance required for the KPI and the grant. So yes, we are living in an environment that is conducive to ethical distress, which arises several ethical issues such as conflict of interest, respect for the research participant, lack of supervision and power imbalance, social injustice, inadequate ethical guidance, epistemic injustice, etc. So these ethical violence affect scientific quality and can harm emotional well-being of both researcher and participants. So why there is need of bioethics training for the CBR researcher and the volunteers? This is because community-based research is projected to grow in underdeveloped and developing countries as a method to address the complex regional specific social and the health challenges. Researchers and the volunteers may unintentionally engage in practice that overlook cultural sensitivities or ethical standards, potentially harming the community they aim to help. And bioethics training is essential to prepare the researcher and the volunteer for these challenges. It promotes the ethical awareness, equip them to recognize and address the ethical issue, and foster cultural sensitivity when interacting with diverse communities. So, keeping all these rationally and the possible breaches of the research ethics in mind, we developed the workshop aimed to access the researcher knowledge and the perception. The workshop had three objectives. The first was to build a solid foundation by the session of the workshop covering core topics including research ethics, informed consent, cultural competence, and handling sensitive topic and the data confidentiality. After the workshop, we conducted the post-workshop data collection, and the collected data was processed and analyzed to assess the effectiveness of the workshop. Our workshop was featured by the four speakers. Dr. Nisa and Dr. Sarifa was supervisory team as well as the speaker, while Prof. Julia and Dr. Rumana were invited speaker. While talking about the overview of the tool we used a questionnaire tool that was divided into three different parts. The first was demographic information. The second was knowledge. So knowledge was further divided into two parts. So the first was on the knowledge of the basic principle in medical research, comprises 15 questions, and the second was the knowledge on ethical code or the standard that included Nuremberg Code, Belmont, the Declaration of the Helsinki, and ICS-GCP. And the third was perception. So perception of the participant on four fundamental principles of the ethics comprises of the 8 questions, and the perception of religious differences, marginalized social, economical, and cultural incompetency at a study site comprises 8 questions to assess the perception of the participants. A part of result, this slide presents the demographic characteristic of the participant in the workshop. As shown in the participant average age was around 32 years with little changes from pre to post workshop. We had diverse ethnic representation with majority of being Malay followed by Chinese. In terms of the gender, more female participants were seen than male, and most of the research volunteers involved in the CBR were research students of diverse expertise who have only minimal exposure to the bioethics in their curriculum. So this slide will show the effectiveness of the workshop on participant knowledge of basic ethical principles in medical research. So the data were normally distributed and was checked using the Shapiro-Willing test. And since data was not normally distributed, we performed non-parametric related sample Wilcoxon sign rank test, and the test shows a statistically significant improvement in the score from pre to post workshop with Z value of 3.089. That signifies the median increase in median from 9 to 12, and the p value was less than 0.05. So this positive difference in a score suggests that workshop successfully enhanced the participant understanding on the basic principle of the bioethics in medical research. Effectiveness of the workshop on knowledge on code of the ethics was assessed by asking, are you familiar with the ethics code or standard? And the data was processed and analyzed using the McNamara test. And this McNamara test revealed a significant change in knowledge of the ethical code of standard between pre and post workshop with p-value of 0.02. Before the workshop, awareness of the code like Nuremberg Code, Belmont Report, ICH, GCP was limited. However, the post-workshop familiarity increases considerably with 86.7% of the participants are aware of the Nuremberg Code and the Belmont Report, and 100% aware of the Declaration of the Helsinki, and over 50% are familiar with the ICH GCP. So this result demonstrates a positive shift of the participant understanding of essential ethical standards. So while looking into the effectiveness of the workshop on the perception on 4 fundamental principles of ethics among the participants, we found that there was a significant negative difference between pre and the post workshop measurement with Z value of -2.283 and P 0.022. So the most differences were negative, accounting 12 questions. That was indicating that the post-workshop perception value was generally lower than the pre-workshop value. And this decrease in perception score, like post-workshop, may reflect a reality check effect on the participants. Increased awareness can sometimes make participants realize that ethical principles are not always straightforward, leading to a more critical or the cautious perception post-workshop. So the result from the perception on religious difference, marginalized socioeconomic and cultural incompetency, PRMC at a study site, revealed that there was no significant difference between pre-PRMC and post-PRMC with Z value of 0, and the majority of the difference were ties, accounting total of the 14 questions, and PRMC of the researcher at a study site was not influenced by the workshop. So the topic like religion, socioeconomic status and the cultural competency are often deeply ingrained and shaped by the personal experiences, cultural background and long-lasting belief. So a one-time intervention may not be sufficient to challenge or alter these complex perspectives. So while examining the overall correlation, we found that the higher knowledge score on the ethics post-workshop were associated with the lower perception score against the PRMC, and it again confirmed that participants gain more knowledge about the ethical principle, they become more critical or cautious in their perception related to the marginalized socioeconomic and cultural incompetency study setting. In conclusion, the finding emphasized the importance of comprehensive bioethics training for the health researchers. Current workshop was effective in increasing knowledge on basic ethical principles in medical research, and it significantly enhanced knowledge on the ethical code or standard. However, it was insufficient to elicit the distinct understanding necessary to change the perspective of researchers in diverse and vulnerable population-based research, which may be due to the time effect, and secondly, the awareness and the consciousness of the researcher after getting the knowledge. So the moderate post-workshop shift in attitude among researchers toward cultural understanding and the community engagement highlight the need of integrated training approach that connect the ethical code with real-world applications. This leads to the end of my presentation. Thank you everyone. Have a great time.
Thank you, Ashok Mandal, for your nice presentation. Actually, we have allocated time for each presenter for 12 minutes, and we will have discussions around 3 minutes after all presentations at the end. So I would like to request to all to note all the discussion points during the presentations, and we'll discuss later on after all presentations. Okay. Thank you, Ashok ji. And you have highlighted the importance and the significance of the research and ethical training for the community volunteers. That is very important topic for the research ethics. Thank you.
Thank you, Pradeep. And the next topic is enhancing the role of lay members. Will be presented by Namtip Smelswar, and it's time for yours. Please.
Good afternoon, Chair and all participants. I'm delighted to speak at this 24th FERCAP International Conference. Today, my topic is enhancing ethical oversight. The role, I'm talking about the role of lay members in research ethics committees in Thailand. So my name is Namtip. I'm Namtip Samerchia. I'm a chair of Human Research Ethics Committee in the Humanities and Social Science from University of Phayao in Thailand, in the northern part of Thailand. I'm also the assistant professor in public administration. So today I will share insights from my study on contributions of lay members, or some would say lay person, in Research Ethics Committee, highlighting their critical roles in improving REC performance. This presentation is based on an online survey conducted from August to October this year with lay members across Thailand. The study aimed to firstly identify the range of contributions of lay members in RECs. Secondly, analyze their background and perspectives. Thirdly, understand challenges and propose actionable recommendations. This online survey completed by 54 lay members combined quantitative and qualitative questions. Data were analyzed using descriptive statistics and content analysis in order to ensuring confidentiality and unbiased insights. For the results, I will separate it into 3 parts. The first one is the background and their experience. The second one is the contribution experience as a lay member. The third one is the recommendation. For the demographic of participants of REC lay members, as a sample of 54 participants, the majority of the respondents were female, 69%, and for the degree, they hold a bachelor degree and also master degree. And the age range of lay members are around 40 to 60 years old. And for the background, lay members in Thailand, they had experience from education, and 20% in healthcare, and 18% in community development. So the lay members in Thailand, they were currently working in the public sector, and they have experience from 1 to 5 years as a lay members. Also, the reason to join with the REC was the EC and IRB approached them. The reason to join the EC and or IRB, the majority of the respondents mentioned about their recognizing the importance of protecting the volunteers. And the second one is they would like to use their experience as part of the feedback to process the human research. According to the experience that support the ECOIRB works, they also mentioned that they utilize the social work experience and also the medical related work experience. For additional experience to incorporate into ECOIRB work is on the current work experience. So the perspective that apply to the EC work is the volunteer, the first one is the considering the risk and the benefits of participating research project. The second one is the volunteer protection. So according to the opinions and also their perspective, they mentioned that every time their perspective are fully utilized in the reviewing process. For the working environment, in terms of the communication and also the scheduling and the adequate training in reviewing process and also the quality of meeting management, lay members are very satisfied in the arrangement of the REC. So the survey also uncovered the key challenges in performing ECOIRB work. The first one is the skill gap. 68% are underprepared to address complex and also the interdisciplinary research. And 60% of lay members mentioned that they are requested in training on emerging technology and also ethical dilemma. And for about environment, 45% felt their opinion were not fully utilized in discussion. And for some of lay members also mentioned about the role misunderstanding. According to the statistic, 40% admitted to being unclear about their responsibilities. And also there is some issues on the selection or the recruitment of lay members. Maybe some of IRB, they have their own selection criteria. So they gave the comments on concern about selecting members based on capability. So about the requirement on skill enhancement activities, the lay members mentioned about they would like to learn more on the case study on ethical consideration in human research. So also the consideration on research project in vulnerable groups, and also the consideration of the risk level of the research project. So for the recommendations and improvement ideas, the first one is the continuous training. For 70% of respondents emphasize the need for annual or biannual training. The training topic that they mention should be include case studies and complex research scenarios. And the last one is the emerging ethical challenges. The next recommendation for improvement is the improved selection criteria. 50% recommended criteria align with the international standard, and also preference should be given to individuals in diverse relevant experience over some topic. And third one is the role definition. 60% of the respondents there suggested clearer guidelines on responsibility, including evaluating risk and fostering collaboration in the domestic and also international. And next recommendation is about the knowledge sharing. So 55% value platforms for real-time idea exchange, such as Line groups, and also networking opportunity both domestically and internationally were highlighted as a crucial for better decision making in reviewing protocols. The last one is the informed consent processes. 65% recommend increased focus on ensuring clarity, privacy, and freedom for participants. For conclusion, lay members are indispensable in safeguarding the ethics of research in Thailand. They also need continuous trainings, clear role definition, and improved collaboration. So strengthening the role of lay members ensures scientific integrity and also protect research participants. Together can make the reviewing process more effective. Last but not least, I would like to extend my gratitude to Professor Chantra, who initiating this idea or this online survey, and also Kun Marisa from HSRI for assistance in distributing this online questionnaire. And also, finally, I would like to thank all lay members who complete this survey. Thank you for your attention.
Thank you, Namtit, for your nice presentation. Now we open for question and answer. Any question from? Yes, please. Maybe please introduce
Hello.
Introduce
yourself. My name is Mohan Raj Sharma. I am the former ARB chairperson at the Institute of Medicine. So you said that you need to train the layperson. That is one of the recommendations from them. But if you train them, then they no longer will be layperson. Is that correct, or I am misunderstanding? Lay means they should be really lay, so that from the perspective of the participant, the moment that you start training them, they will no longer be layperson. What is your take on this?
Thank you for your question. Actually, for training, it means that the training about the international guidelines or the issue about research ethics. Not only the scientific issues.
you know, it's okay because it's close to each other, so we make noise. When we say we train lay person, we train them to know their role, okay? Because in the guideline also require the lay person to be one of the voice, no? Very important person. If you don't have that person, you cannot have the meeting. So if you said, oh, anybody can come, but they don't know the rules, they have to know the rules. They have to know the ethics. They have to know about that. When the person becomes vulnerable, what does it mean by that? You see? So I think we have to ensure that the person who are so important know exactly what they're supposed to do in that meeting. Okay? Chandra. And then the other one. Any question? Yes, please.
Thank you. It was a very wonderful and informative presentation. But I would like to ask you a question. It's really very important to train our layman participants in the research, particularly in point of ethical. But could you please elaborate? How did you train? What are the methodologies you have applied? It will be really helpful to us also. Can you please elaborate on that part, please?
Thank you for your question. May I repeat your questions again? I mean, you mean how to train the layperson? What, in which perspectives, right?
Yes. What are the methodologies you have applied to train them? Because training means, participants need to understand thoroughly about the research part, ethical part, involvement part, right? And it's really very important part. So I really appreciate the presentation you have presented. Please help us. Could you please elaborate it? How did you train? What was your practice? How did you manage to train your participants? And what are the field subjects you have taken to train them?
Okay, as far as I know, the Thailand public governance, namely health system research institutes, they arrange the training program. Actually, the training program also rely on the lecture base, and the other activity based on the case study discussion, just to learn the reviewing process. And also, as Professor Chandra mentioned, also from the survey, the result from the survey is shown that the members are not understand that rules. And also some guidelines. Why should I be here, for example? Maybe it's still ongoing project. Maybe Professor Chandra, you would like to add some points?
Okay. You from ethics committee? Yes. Okay. What's your lay doing? What do you expect from your lay?
I want my participants to cooperate us in the field of research. He should understand what I'm doing. He or she should understand in the proper local language what I'm doing, what is his role, how it is going to get benefited to the translational research. When I talk about the research, I mention translational research, which should be directly benefited, or in future it should be benefited to the patient per se.
So what is your role in the ethics committee?
Okay, I'm a member of the institutional ethical committee.
Science, you are.
Yes, in health science, yes.
Okay. When we, just like he said, if the lay is not the lay anymore, so what can it, what they can benefit us, no? They should remain as a lay perspective, but they should not be scientists.
Yeah.
Okay? True. So, in the ethics committee, the lay may not understand the methodology and all those things because somebody else is telling them. The lay person is supposed to evaluate whether that risk in that study acceptable for them as a lay person or not. For example, if you are a medical doctor, you see the patient, you take the blood from the patient all the time. 100 ml, that is fine, it's okay. But in the terms of the lay person, how do they feel? Is that too much as a lay person? You see? Because we already bias automatically as a scientist. We have said, wow, it's very important. That is nothing, you see? So that's why it's so important the layperson know exactly what they're supposed to do. They should be representative, but at the same time, they should know about the rule in ethics. We have to talk about risk, talk about benefit. They also, another important role is for them to read our informed consent. We have a problem from many centuries ago. We still at the same place right now. They don't really understand. So that's why we have to train them how to read that, how to make a proper recommendation than just say, oh, I don't know. When I read it, I don't understand it. It should not be that way because we also have to help the investigator a bit, no? Because investigator is a scientist. So when they look at it, they say, well, so it's simple. Why can't you understand it? So maybe if the lay can understand that and the lay know how to help the researcher a little bit, that what do they mean by they don't understand, what are the terms that should use and things like that. I think it's very important that we train the lay. I think there are another country that train the lay, I think Taiwan or something. Yeah. So I would encourage your country to look after that because the lay person is so important. You allow them to be the one who say yes, no, and here and there. And then they don't know what they're supposed to do there. Okay.
Thank you.
Yeah, thank you, Juntra, for highlighting the role of lay. Yeah.
I have
Lisa.
another question. My name is Lisa Heberlein. I'm from EUREC, the European Network of Research Ethics Committees. And I was wondering if there's a specific reason why you included people with a very actually high academic level of education. You said that they were from the public sector, also from the health, they had health education already. And I wonder if you would also consider involving people with, yes, not that high of an educational level. Or maybe also what differences it would make in the training.
No. The training is my program. But I asked her to do on the part of as a social scientist. Okay? She got a grant from the social science. Because I'm wondering, all the lay person, after we train them, what do they, things like that. So I asked her as a social scientist. So she has some number there in the PhD. You have, yeah, some PhD, which we try to tell everybody that you don't get PhD. But existing ethics committees, some of the ethics committees still have those PhD. PhD in what? In law, in educate, something else. But the scientist is scientist, no? If you are PhD, that means you're scientist, no? A scientist in one way or another, a hard science or soft science, that's still scientist. So that's one, she got a few of that. We try to, when we announce for training, some of them may get involved without we knowing that they are PhD. Actually. So that's why they got involved with that. But maybe some of that, all the trainees. Yeah.
I think that discussion is going very smoothly, but due to time constraint,
yes, okay.
Leave it there, and we can discuss at the end of the session.
Yes.
Yes, thank you.
Thank you for your patience and
for your very clear sharing for us. We should move to the next topic, please.
Yeah, thank you. So we have next presenter. So he's Professor Dr. A.T. Norwing, solely MD, MSc, MMed. His current position is the Secretary of Medical and Health Research Ethics Committee, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, served Jitu General Hospital, Indonesia. And highest education attainment is the doctoral degree in pharmacology, Universitas Gadjah Mada, Indonesia, And her expertise is the experimental pharmacology, drug development, and toxicology. She is the head of the Department of Pharmacology and Therapy, Faculty of Medicine, Public Health and Nursing, UGM, member of Indonesian Pharmacology Association, member of IPHAR, International Union of Basic and Clinical Pharmacology, and she is the member of FERCAP 2012 and now, and she is member of Material Transfer Agreement Committee, Ministry of Health, Indonesia. Thank you, Professor Doctor, having with us. Please go ahead. So we'll discuss at the end of the sessions, maybe.
Okay.
Thank you.
Okay. Good afternoon. Thank you for giving me time to present our work with title Common Issues Faced by Researchers During the Development of Research Protocol Related to Health Innovation. Yeah, as we know that the research in health innovation drive advancement that improve patient care, treatment outcome, and also overall public health. And the process of ethical review is a critical component of research integrity, ensuring that studies adhere to established ethical standards and protect the right and welfare of participants. And however, researchers often encounter significant obstacles when developing study protocols, particularly during ethical review process conducted by ethics committee, which maybe can delay the approval and implementation of their studies. We have conducted study to identify common issues faced by researchers during the protocol development of research protocol related to health innovation. And data were collected from the review of all clinical research protocol related to health innovation from 2018 to 2023 in our ethics committee, in Medical and Health Research Ethics Committee of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Sarjito General Hospital, Yogyakarta, Indonesia. And the results showed that a protocol related to health innovation can be classified into vaccine, and then software or application, medical devices, traditional medicine, non-pharmacological intervention, food supplement, drug and medical procedure. And we can see the result from 2018 to 2023 here. And through comprehensive evaluation of the review, we can see some area that researchers lack or make mistaken, include lack of clarity in study design, insufficient detail regarding informed consent procedure, inadequate risk-benefit analysis, poor justification of sample size, lack of appropriate plans for adverse event, and insufficient consideration of vulnerable population. And all issue related to protocol related to health innovation, we identified some problem, includes appropriateness of methodology, declaration of conflict of interest, GCP training for researcher, appropriateness of informed consent, and completeness of investigational product information. From this table, we can see that the most problem is about informed consent, yeah, and then methodology, and then good clinical, investigational product, and all related to good clinical practice, conflict of interest and good clinical practice. When we see in the diagram, it is easier to see that the most problem is about informed consent. Yeah. Among 5 problems that we can identify. So this is important to us to make a plan what kind of training need conducted for researchers. This is 5 topic for the training. Yeah, thank you very much.
Thank you for your very important short and sweet presentation. So I think, shall I go for the discussions or we'll go for next presentations? So that's up to the present, participants. Next presentation, okay. Thank you, Professor. Yeah. For finishing on time also, yeah. Thank you.
Good day, everyone. Today, I'll discuss how the Single Joint Research Ethics Board, or SJREB, is improving Research Ethics Committee communication with research stakeholders, aiming to create a more effective ethics review process. Hello, I'm Kevin G. Martinez, a Health Program Officer at the Department of Health in the Health Policy Development and Planning Bureau, Health Research Division. I've been with the Department of Health for 5 years and have served as an SJREB Secretariat for almost 1 year. I hold a bachelor's degree in communication from Far Eastern University, class of 2019. The Single Joint Research Ethics Board, or SJREB, was institutionalized in the Department of Health, or DOH, through the issuance of Administrative Order AO number 2017-0021 in October 2017, titled Guidelines for the Operationalization of the Single Joint Ethics Review Process for Multi-Site Researches in the Department of Health. This initiative has been put in place to streamline the ethics review process within the department and to contribute to the improvement of the research ethics governance system in the country. SJREB began operation in March 2018, serving as a platform for joint review of multi-sites research studies sponsored by or implemented across Philippine DOH-retained hospitals. In 2019, to enhance transparency and improve processes, SJREB achieved joint accreditation from the Philippine Health Research Ethics Board, or FREB, and Forum for Ethical Review Committees in the Asian and Western Pacific region, or FERCAP. This accreditation led to the issuance of AO number 2019-0049 titled Guidelines for the Operationalization of the Single Joint Ethics Review Process for Multi-Sites Researches in the Department of Health, which established guidelines for a single joint ethics review process, addressing issues and refining procedures for multi-site research within the Department of Health. There are several key challenges in the coordination process. First, duplication of the efforts is repeating issue, with emails often being duplicated and post-approval submissions sometimes resubmitted. This leads to unnecessary repeated reviews and the creation of decision letters. Secondly, manual processing remains a significant challenge. Unlike other research ethics committee or RECs in the Philippines, SJREB does not yet have an online processing system, and operations are primarily conducted through email, which slows down efficiency and creates room for errors. Lastly, the lack of standardization in the SJREB Standard Operating Procedures, or SOP, creates gray areas, requiring decisions in complex situations without clear procedural guidance. Addressing these challenges is crucial to improving the coordination and efficiency of the ethics review process. Effective communication is key to overcoming these challenges. By maintaining clear communication with local RECs, principal investigators, and sponsors, we can reduce duplications and ensure a more efficient workflow. Timely decision-making helps clarify requirements, reducing delays and speeding up multi-site ethics reviews. Transparency and trust are built through timely updates and clear guidelines, fostering stronger relationship with RECs, principal investigators, and sponsors. Finally, stakeholders' engagement keeps everyone informed and involved, ensuring continued support for SJREB's ethics review. This study aimed to assess SJREB's communication practices to identify and address bottlenecks. By streamlining communication, our objective is to improve the overall ethics review process, making it faster and more efficient without sacrificing quality. For impact assessment of SJREB research methodology, we use the mixed method assessment of SJREB's communication system. First, document review. Analyze institutional policies and meeting minutes. Second, survey. Collected quantitative data on communication effectiveness, clarity, and frequency. Third, focus group discussions, or FGDs. Gathered qualitative feedback and improvement suggestions from stakeholders. For the stakeholders surveyed, our participants, first, REC members and staff. Second, sponsors. And lastly, principal investigators provided insights. For feedbacks, consistently reported gaps in communication, such as delay and lack of clarity in requirements. One of the issues identified with site RECs was the non-attendance of some REC representative at SJREB full board meeting, lead to a lack of quorum, which in turn results in the rescheduling of protocol reviews. This issue is further compounded by scheduling conflicts, including other commitments of the SJREB Secretariat. And lastly, there is a lack of proactive engagement between site REC staff and SJREB Secretariat staff. We also found some consistent issues with sponsors and investigators, such as prolonged response times, submitting incomplete requirements just to meet the submission deadline for inclusion in the next full board meeting. Multiple emails or duplicate submissions to SJREB result in repeated reviews. Unclear interpretation of SJREB standard operating procedures and the use of incorrect forms lead to resubmissions causing delays. We also identified frequently asked questions from stakeholders. Sponsors often inquire about which REC sites are involved in specific SJREB activities and the standard turnaround time for reviews. Principal investigators commonly ask whether it's possible to submit directly to SJREB and bypass local RECs, and if a single form can be used for submissions to both SJREB and local RECs. For RECs, frequently asked questions revolve around the standard time frame for releasing decision letters and meeting minutes, as well as when invitation will be sent out for full board meetings. Addressing these common inquiries will enhance transparency and streamline the process for all parties involved. SJREB has already implemented solutions to streamline processing, including the revision of SOPs with defined timelines and the creation of a Viber group for SJREB members and RECs. These actions enhance information, accessibility, and assist stakeholders in navigating the review process more smoothly. For effective communication, we have appointed a communication officer to ensure prompt responses and created a Viber group for getting updates, with a 3-day response time for all inquiries and submissions. To enhance database utilization, we have developed an updated directory of RECs and sponsors and consistently maintain the SJREB database. These measures reduce processing time, improve accuracy, and enhance overall stakeholder satisfaction. Our targeted training programs have brought 2 main benefits: increased efficiency and better coordination. Process efficiency. Training has reduced redundancies, allowing for faster and more accurate processing. Staff now have a clearer understanding of procedures, which keeps our reviews on schedule. Coordination. This program also improved coordination between SJREB and local RECs, aligning our teams and making collaboration smoother and more effective. In summary to this, targeted training has streamlined our operation, leading to a more efficient and unified review process. We've seen 2 key improvements as a result of our recent changes: enhanced engagement and greater transparency. Enhanced engagement. With clear communication channels like the Viber group for real-time updates, stakeholders are now more informed and involved in the ethics review process. This active engagement leads to fewer missed deadlines, smoother workflows, and stronger collaboration with SJREB. For transparency, clear guidelines and defined timelines have made the review process more predictable and open. Our new communication officer also ensures that inquiries are answered quickly, helping stakeholders feel confident and reassured. This improved transparency builds trust and support a positive perception of SJREB. These improvements in engagement and transparency create a more efficient, trustworthy, and collaborative ethics review process, benefiting both SJREB and our stakeholders. In conclusion, the improvements made have positively impacted the quality of ethics reviews. Capacity building and training have strengthened and competence and effectiveness of research ethics oversight. However, continuous efforts are needed to further enhance SJREB operations. By improving communication and seeking feedback from stakeholders, we can increase awareness and engagement, leading to stronger and more efficient ethics review process. Looking ahead, SJREB will prioritize refining our communication strategies with a strong focus on continuous feedback from stakeholders. Effective communication is a key to maintaining our high standard and ensuring we adapt to the evolving needs of ethics review. These ongoing efforts will help us stay responsive and improve our processes, fostering greater engagement and trust. Thank you for your attention. If you have any questions or need further information, please don't hesitate to contact the SJREB Secretariat using the details on the screen. The Single Joint Research Ethics Board is dedicated to ensuring effective ethical oversight in research, driven by open communication and continuous improvement. Together, we can uphold the integrity of research and foster ethical practices.
Okay, thank you, Kevin, for your clear and good presentation. Are you still there? Hello. There is no. Maybe she's not in contact, and we move for the next topic. Yes, please.
Thank you. We have last presenter, Professor Dr. Mohanraj Sharma. He is currently working as a professor and head, Department of Neurosurgery, Trivandrum University Teaching Hospital, Kathmandu. Actually, he is my senior also. Past president, 2017-19, Nepalese Society of Neurosurgeons, Nepal. He is the founder, editor-in-chief, 2004 to 15, Nepal Journal of Neuroscience. He is the director of research, Institute of Medicine, TU Nepal, 2020 to 2023. So he has many publications. He has more than 140 articles in peer-reviewed journals, both national and international. So he had published the 8 book chapters. He was contributed for the formulation of the 2 national guidelines for the head and spinal trauma. His special interest is in the biostatistics and public health, and research and publications research equity. So we would like to welcome Professor Mohan Sharma for your valuable presentation. Thank you.
Thank you. Thank you, Dr. Ganwali and co-chair. Slides here. It's very difficult. It is hard to attend the after lunch sessions, and equally harder to deliver the session. So this time I have chosen the topic ethical issues in reporting research results. So ethical issues in conducting the research is right after this session downstairs. Okay, this I don't read. I like to, and this is the hospital where I work. This is a Trivandrum University Teaching Hospital, 850 bedded multi-specialty tertiary level hospital. This is where I work as a neurosurgeon, and part of the extra time I use is for research. And this is the reason why I am here. I like to start my presentation with this quotation from Joseph Conrad. The belief in a supernatural source of evil is not necessary. Men alone. It also includes women as well. Men alone are quite capable of every wickedness, and this was true in scientific writing as well. So briefly to introduce the topic, what is scientific misconduct? It is a behavior by a researcher that falls short of good ethical and scientific standard. The catch is in the definition. What do you mean by good ethical or scientific standard? So it's subject to interpretation by many, but this is what they have given. Another way of saying this is unacceptable behavior in proposing, performing, and reporting research. This was given by US FDA. So a lot of you can interpret the same thing differently, but if something is quite obvious, then you can say somebody has committed scientific misconduct. But why does this happen? My previous speakers have also touched upon poor supervision. We train our residents and students in our training, but if we do not supervise them, they are going to do bad things. Another, too much work or academic pressure. We are clinicians, we work in the hospital, we operate in the OR. At the same time, we are supposed to do the research, then, if you have multitasking, you are going to make mistakes. Somebody said earlier, publish or perish culture. This happens in big academia. Unless you churn out papers every year, 4 or 5 papers in Q1 or Q2 journal, there you may be kicked out of the program. So that is the reason why sometimes people cook up data and publish. Okay. Incentive for enrolling or financial gain. People have committed crime, academic crime, because somebody bribes them. That is another reason. It's an issue. Okay, you know this Latin, irare humanum est ignoscere divinum. You know the meaning? Yeah. To err is human, to forgive divine. So if you commit mistake once, you will be forgiven. Irare humanum is persevere autem diabolicum. It becomes automatically devilish when you commit the same mistake again. This is what we need to remember in our research work also while we repeat. So this was a study quite old, 2009. Gilneski did this study. It doesn't mean that the younger the person, worse the thing. Even the professor, those post assistant professor or scientists, 17% of the time they are the one who do the bad thing. So we need to know this. And what are the types of scientific misconduct? Bad thing you can do is fabrication, falsification, plagiarism, research without prior IRC approval, selective reporting, industry funded, conducting research without informed consent, p-hacking, if you are, you torture the p-value, you want to have the p-value significant, so you want drug A to be superior because the trial was funded by the industry, then that's what called p-hacking, and gift and ghost authorship. This also happens. I'll briefly touch upon all these things. Well, I need to have extra time, because this doesn't work. So these three forms of fabrication, falsification, plagiarism are called the three cardinal sins of research, which we should never commit. Unfortunately, these bad things are the one which dominate in the list of bad things you do. So what is fabrication? Fabrication is the outright manufacturing of the data. Data doesn't exist and you just create them and publish. If you are working in the lab, it's called dry labbing. So you just report the hemoglobin, TCTC, blood glucose, and it doesn't exist. Your lab doesn't exist. That's called dry labbing, and I just said this. And what are the possible consequences? You can just get away? No, many things can go wrong for you. You will be blacklisted from the profession. A reputable research organization, university will refuse to hire you. You don't get any fund, and journal will not publish your work. That means you are intellectually a dead person. So never ever think of fabricating. I'll give this example. Dr. Wang Wusuk, when I was just back from my training in 2003, he was the man everybody looked up to. He was considered a pioneer in stem cell research, but however, he fabricated data on stem cell research, and he published the article in Nature, Everybody's Dream, that was retracted, and he embezzled money from the government. Plus, he coerced his female lab workers to donate egg, in the meat cycle. Eventually, he was found guilty of all the fraud, and he was sentenced to jail. Very, very bad thing. This fabrication. Haruko Obokata, she was considered as a brain with a beauty in Japan back in 2014. She published paper in Nature on staph cells. This is the paper she published, stimulus triggered fat conversion somatic cells into pluripotency. But her results were too good to be true, and her peers were very suspicious of her work, and they officially lodged complaint to the Japanese government. Japanese government gave her money to replicate her experiment again and reproduce the results. Of course, she could not, because it was never done. So this paper was retracted from Nature, after 4 months. If you see at the citation, when her first paper was published, she had 262 citations, but the retraction had 263. If you commit bad things, that the information goes faster compared to if you do good things. And another bad aspect of this was her supervisor felt so humiliated that he committed suicide. So that is the implication of fabrication. So let's talk about the falsification. Falsification is willful manipulation of the data or image to obtain the desired result. Data is there, but you just manipulate to get the desired result. I'll give the example of this gentleman. He is a qualified dermatologist working in New York. So what he proposed is he would transplant the skin of the black mouse and transplant into the white mouse. And then eventually the melanocyte from the black mouse will migrate to the white mouse. But what he was doing was, in the night time, he was painting the white mice with a black pen. So this is what just people get overwhelmed by the need to be famous. Now painting the mice has become a synonym for research fraud. So he created idiom. So this we should not be doing this. So let's talk about this gentleman. He was the director of the Cardiovascular Research Center in Colorado, University of Colorado. What he proposed is, if you drink the wine from this grape, this is the thing you will get. What's the name of that thing? Is resveratrol. Resveratrol is the component that is cardioprotective. That was his proposition. And he published so many papers in Q1 journal, Lancet, everything. But, then when you publish things which are too good to be true, then people will raise question. And then eventually people question his data. And what was found was resveratrol is indeed cardioprotective, but you need to drink 2 liters of wine per day. So clearly there was falsification of the data so that, so this is another, you go to the net, you get so many examples, so I just give 3 representatives. Plagiarism, everybody knows, I don't want to spend time, and this has become the modern pandemic in the academia, copying and pasting, plagiarism. You can do direct or mosaic plagiarism. Now, and self-plagiarism also, that is there because you publish a series of 20 patients last year, now you add 2 more patients this year, and now series of 22. That is what salami slicing is. And I will give you this example. I mean, we are no exception in doing bad thing here in Nepal as well. The previous paper was published in 2011, and another paper was published in Bali Medical Journal in 2013. See the first abstract, infertility is one of the medial, social, and psychological burden. And the another paper also, infertility one of the medial, social. Even the spelling mistake is also copied. See that? It should be medical, social, and psychological. It should read like that. But those who have copied have even copied the spelling mistake. So this is the flagrant way of doing plagiarism. Now we have become very compulsive about checking this plagiarism in our university. So we do Authenticate as a software to detect plagiarism, and everybody has to go through this Authenticate check before they submit their paper. I have the YouTube channel also. I have I have a detailed lecture on how to use plagiarism here. If you are interested, you can do that. And our university. Yes, this is what our university's rule is this. You cannot have 0% similarity, just impossible. So PhD should be less than 10 and MPhil 15, Masters 20 and all these things. So only after checking with Authenticate it can be submitted. Ghost author and gift authorship are also very common. Usually ghost author is the author's name does not appear in the final publication. Usually happens in industry sponsored thing. Guest and gift author are usually somebody who is the head of the department or big person. His name is just put there to make them happy. Should not be done. Predatory publishing and journal have also come, very aggressively. So scholars are tricked into publishing with them. And ICMJ, International Committee of Medical Journal Editor, they recommend, let's not say predatory, let's say pseudo journal. Because even if you know they are predatory, you submit to them. That's why they say let's call pseudo journal. The behavior is same. Let me just go back. The behavior is same. There is technically no peer review. Very short, probably you submit today, tomorrow the paper will be out. They charge minimum for publication. If they charge high, usually the high-end journals charge high, $3,000, $4,000, but they don't charge high. But they go into masses. And email advertisement is their signature style. So I get this kind of email every other day. So this is say the dear author, they don't even bother writing my name also, and this is this. And also you can also tell your friends about this journal. I like this sentence a lot. So this is the thing. And how you detect predatory journal, there are multiple websites where you can get, and Bill's list is the most trusted one. If you the journal you are proposing to submit to is in the Bill's list, please do not submit there. About how to discourage scientific misconduct, we need to generate awareness among your researchers about the bad aspect of this. Use of anti-plagiarism software like iAuthenticate, and no submission and no citation from the predatory journal. This is how we discourage scientific misconduct. So to conclude my presentation, I put this quotation from Buddha. This is the country where Buddha was born some 2,500 years ago. Three things cannot be long hidden: the sun, the moon, and the truth, plus scientific misconduct, I'd like to add. Thank you so much.
Thank you, Professor Dr. Mohan Sharma, for your excellent presentation. If you have any comments, suggestions, you are highly appreciable. And yeah. Any questions, comment for to Mohan Sharma?
Okay. None?
So if there are no questions, thank you very much. If you have any comments for the past presenters, so that is also welcome. So otherwise, we would like to conclude the sessions. We would like to thank from the chair's side to the presenters, Ashok Kumar Mandal, and he had concluded the importance and the significance of the research bioethics need, training for the community volunteers and researchers. And our second presenter was the Noom Tip from Thailand. She has highlighted the enhancing the role of the layperson and the members, and her recommendations were the need of the continuous training for that layperson, and the role of the EC committee and alignment of the standards for the EC committee, improvement of the selection qualifications and criteria for the research. And she also highlighted the enhancing collaborations, knowledge expansion, and she has highlighted the focus on the informed consent. So our third presenter was the Professor Dr. Ethi. So he has highlighted the addressing common issues of researchers during protocol development. And we have the another presenter online, Kevin G. Martinez from Philippines. So the topic was the Single Joint Research Ethics Board, SJREB, for multi-centric protocols development. And that is also very new for us also. And the coordination challenges, duplication, manual processing, importance of the effective communication he has highlighted. And our fifth presenter was the Professor Monga Sharma. And he has nicely presented the ethical issues in reporting research results. And so he has started his presentation from some quotations, and the end of the presentation from also quotations. And so he has highlighted for the need of the supervision of the researches and effect of the workload, publish and perish purpose of the research, and incentives. So these are the things you should consider before the publications and the research. Very nicely presented, and he has given some of the examples of the fraudulent publications, fabrications, falsifications, etc. Thank you very much for all the presenters and the participants who has presented nicely, and the participants he has significantly contributed for during the presentations. Thank you very much. I think we would like to conclude this session. So do you add something? Yeah, thank you.
Thank you, sir, for your closing remarks. A heartfelt thank you to all the presenters for their thoughtful and impactful contribution. Your work has shed light on practical solutions and innovations to enhance REC performance and communication. I now would like to invite the presenters to come forward to receive a token of appreciation and kindly request our session chairs to present the token of appreciation. Please join me in applauding our presenters as they come to the stage. Dr. Namtin Smarshar, you can go. Okay. Dr. Eti Norwening Sholika, Dr. Mohan Raj Sharma, I request all the presenters and chairs to stay on stage for group photo. Presenters, please come on stage for group photo. Thank you. To conclude, I invite Dr. Mrigendra Raj Pandey, Emirates Chairperson of NHRC, to present tokens of appreciation to our session chair for their leadership and guidance. Thank you, sir and ma'am. As we wrap up, I extend my gratitude to our chairs, presenters, and all participants for making this session an engaging and insightful experience. We will now take a short break. Please return to main hall by 3:45 p.m. as we continue with the program. Thank you. Enjoy your break.